overview of the Ottawa Model for Smoking Cessation, or OMSC, which many of you may have come across, and if you haven't, we're more than happy to talk to you about it afterwards as well if you're interested in implementing it in your different centers. And so we'll talk about how you can adopt smoking cessation into your clinical practice. So first and foremost, starting off, examining the issue of nicotine use. So why is it still important to address? As many of us already know, smoking is a leading cause of hospitalization and rehospitalization. I often will, and there's like 1.4 million hospitalizations that are attributable to tobacco-related disease in Canada annually. When we think about smoking, obviously there's the hospitalization aspect, but death and disability, there's not much in the world that's leading in terms of the causes of death and disability than smoking and smoking-related disease. At least a quarter of our heart disease patients are smoking as well. And so it's very important for us to recognize that. But even in our primary care settings, it's important to recognize the importance of assessing and managing patients that smoke. As mentioned, it's a leading cause of preventable death and disability across the world. I could literally stand up here and give an hour lecture on the impacts of smoking and smoking on health, but I won't bore you with that information. But I think one thing that I do want, and I'll talk about some of the stuff on the slide shortly, but one thing I do want everybody to consider is that often smoking is considered as a vice, or it's considered something that people choose to do. We really need to think about it in a more psychiatric or psychological, psychosocial approach, as well as treating it like anything else. It's a chronic disease that we need to manage, just like we manage diabetes. We need to, or hypertension, we should be managing smoking and smoking cessation. And we need to go away from it being a more social or lifestyle choice, and maybe think, or certainly think about it more as a medical issue, psychiatric issue that requires ongoing assessment and follow-up. In terms of the various things that smoking is associated, this is obviously all quite a bit of review, but we know that cancer, probably the leading, for those that smoke, lung cancer is a leading cause in terms of etiology. It causes pretty much every type of cancer you can imagine. When we talk about heart disease, we talk about stroke, we talk about other peripheral vascular diseases, etc. Smoking is often the #1 modifiable risk factor for those that have those diseases, and we know that by stopping smoking, we can avoid death and disability amongst our patients. Clearly, there's lung issues. I know the respirologists love to take smoking cessation as their own, but we at the Heart Institute and in the region have kind of adapted it under our umbrella of cardiovascular health. But clearly, COPD and pneumonias and poor immune status is associated, and we know that smokers often, have worse outcomes as it relates to even things like COVID, as an example. And there's many other. I won't rehash all of these things, but clearly smoking has major impacts on health, and stopping smoking is the best thing you can do to avoid development of disease, development of progression, or having death. Unfortunately, though, smoking still remains prevalent. We've made lots of improvements, but that's not to say that we are anywhere in the clear. Obviously, the government, the Health Canada mandate of 5% prevalence by 2035 is something that we'd like to do. But even up until 2019, we're still at about 10 to 12%. So how can we deal with smoking and smoking cessation? Within our hospitals, we know that about 20% of people presenting to the hospital are smokers, and that number is much higher among those that are admitted for COPD exacerbation, for active cardiac disease, and certainly psychiatric disease. We know that often cigarettes can be used as almost like a bargaining chip with patients in some of our facilities. So I think we need to be mindful of having tailored approaches to these different groups. The same approach that may work for a cardiac patient clearly may not work for your patients in a psychiatric institution. We also know that among certain subgroups of users of different addictions, smoking is much more prevalent. So if you happen to have an addiction of some sort, whether it's cocaine, alcohol, opioids, narcotics, etc., prevalence of smoking is astronomical in those populations, and also with mental health, whether it's schizophrenia, bipolar disorder, or major depressive disorder. So it's important to recognize the patient in front of us and really thinking about patient-centered care, but also thinking about the right patient, the right time, with the right treatment or counseling or management approach that we want to take. And as I said, the same approach that might work for cardiac patients or a primary care patient may not be the same one that we might want to apply for somebody with mental health. thinking about in terms of prevalence and providing some of our own data. So 70% in terms of willingness and readiness to quit. And so of the smokers that are present, based on a Cochrane review by Dr. Rigotti, 70% or so were interested in quitting smoking within the next 6 months. So there is a huge mismatch between the people that are smoking and the people that might be getting the assessment and the advice to quit. But it's really heartening to see that actually over 2/3 of people are interested in smoking cessation within the upcoming 6 months. And within our own data set at the Ottawa Heart Institute and within our OMSC sample and what have you, we also see that over 2/3 of individuals in primary care sites that are partnering with us are interested in smoking cessation within the next 30 days or 6 months. So certainly within 6 months, over 2/3 of people are interested in quitting. And even within our hospitalized patients, again, looking at the next 30 days and the next 6 months, it's almost 3/4. So we know that there's prevalence of smoking. We know that by smoking cessation, we can avoid death and disability. And we know that our patients are interested in quitting. So that's where we come in, hopefully, and partnering with lots of different organizations that exist. But obviously, with our smoking cessation program that is present at the Heart Institute, one thing I should say is, clearly foundations that have been set up over the last 2 decades by Dr. Bob Reed and Dr. Andrew Pipe, it's really revolutionized the delivery of smoking cessation. And really, we stand on the shoulders of giants who continue to work in this field and push the needle forward. And our work breaks down into 3 different arms in Ottawa. So the first is the Quit Smoking program, which is managed by Emily Serrano, who you're going to hear very shortly. And that's an ambulatory clinics that doctors can refer their patients to. Patients can even self-refer, actually, and patients can have appointments with specialized RNs, talk about smoking, have follow-up, etc. And I just want to add one real, I'm just going to take a sidebar here. When we talk about smoking cessation, in addition to the initial assessment, if you don't have follow-up, there is a very low likelihood of continued success of smoking cessation. So we really emphasize the need for follow-up. Just like we're not going to treat our hypertensive patients that we start on blood pressure pills and just say, you know what, take care, good luck. In the same way, we need to ensure follow-up. And the QSP program, as well as some of our OMSC programs, enable that follow-up for communities and hospitals that are unable to necessarily provide that for themselves. So within this clinic of QSP, we have medical directives that are present. So whether it's nicotine replacement, whether it's bupropion or varenicline, et cetera, there's different products that we use to support smoking cessation. And we have had I can't go into all of the details during this particular presentation, but we've evaluated the program, and our success rate is quite high just based on this program that uses a multi-pronged approach towards smoking cessation. Then we have a second arm that is called the Ottawa Model for Smoking Cessation. That's our external reach to the entire community. We have sites, I don't know if I have a map in here, but we have sites literally across Canada. We've got, hundreds and hundreds of sites up in the north and Nunavut. We've got them in the prairies. We've got them, in Atlantic Canada, et cetera, across all of Canada. But also we are partnering internationally with members in the European Union. We're partnering with those in the NHS in the UK, et cetera. And this is something that's managed by Mustafa and Sarah, who will be speaking later as well. And this was among the first smoking cessation programs that was developed, and it was developed at the Ottawa Heart Institute, and that's why it's called the Ottawa Model for Smoking Cessation. And it's been in existence for like 20 years or something before I was in med school. I'll just put that out there. I'm not that old. But just to say that it's been there for a long time, and there has been immense progress that's been made using this model. It's to the point where we have like our 15th annual conference, which some of you may have been in attendance of in the past and maybe in the future, but we have done 15 annual conferences with our 15th one coming up in January 2023, and would love to see you all there if you're interested. But it's just to say that it's a very mature program that's funded through the ministry to support primary and secondary care, like hospital, tertiary care centers, to support smoking cessation, and most importantly, that follow-up piece, without which, unfortunately, people and patients are very much unable to get smoking cessation occurring. So it's just to say that we're able to provide through the OMSC and Quit Smoking program, not just within our region, not just within our patients, but even a systematic approach, a system level approach, which is what OMSC is. And obviously, Mustafa and Sarah will be speaking about that later. So The last thing that I'm going to briefly touch upon, which is the third arm, is their smoking cessation research. And I look at a lot of our activities at the Ottawa Heart Institute in a lens of research, and quality improvement's a form of research. Obviously, when we're doing trials, that's research. Implementation of programs is research. Evaluation of that implementation is research. So we're always looking to try and improve. And we have expertise from individuals like Bonnie Quinlan, who's obviously managing a lot of our wonderful activities and obviously the event today. And it's extremely important for us to always think about what can we do better. And that doesn't happen without QI. That doesn't happen without research and evaluations. And so I've listed a few of our studies here. Some of these are actually CIHR funded, and I'm fortunate to be principal investigator. Some of them are from the Ministry of Health. We've got a wonderful team. We're always looking to collaborate. So if people are interested in collaboration relating to research and smoking cessation, we're always open and would love to hear from you. So some of the studies that we're doing, smoking cessation application to assist smokers that are actually not interested in quitting. Often I'll be talking to a patient in clinic and they'll say, I'm not interested in quitting, I smoke. Well, those patients, we've actually have a CIHR funded study to give them a 14-day program to try and help them quit smoking, and some pilot study data that's been very, very effective and interesting. So that's why we're doing a larger study. We've got use of NRT or nicotine replacement for e-cigarettes. So I think there's a massive area of research niche that we're building at the Ottawa Heart Institute relating to e-cigarette use, and we'd love to partner with many of you if that is something that you're also seeing clinically, as we are quite a bit. E-cigarettes for smoking cessation. Now talking about another arm of post-ACS, we have a CIHR funded study that's multi-center looking at the use of these devices in specific populations. The use of cytosine, which is an up-and-coming medication for smoking cessation. We've got systematic reviews and meta-analyses, obviously. We've got the Initiate study, which is looking at smoking cessation being initiated in emergency departments. We've got the Connect project, looking at hubs across Canada. And then always we're continuously looking for program development and improvement. And so that's continuous program evaluation with reach and effectiveness, and we're publishing concurrently on those types of topics. Exploration on the development of predictive modeling. So we obviously have decades worth of data. We want to come up with a predictive modeling, working with our colleagues in AI and ML, machine learning, to look at whether we can predict who will smoke, who will stop smoking, and who won't, and maybe associate certain resources to those individuals. But at the same time, who may relapse and who may not relapse, and think about whether we can attribute some additional resources to them. So we've got some interesting work in large database, and then of course updating all of our OMSC tools and forms to improve data collection and point of care delivery and provision of care. So on the whole, we've got these three arms of QSP, OMSC, and then ongoing research and knowledge translation, and the conference kind of fits into that piece of knowledge translation. So I think that brings to an end my part of the presentation, but I will be at the front and would welcome any questions at the end. And now I'll pass on to Emily, who I believe has the recorded presentation.
Joining us today, and thank you for allowing us the opportunity to share with you a little bit more about what we do here at the Ottawa model. Some of you may be already familiar with the program, some of you may already be implementing the program, but in essence, for those of you who are unaware, the Ottawa model for smoke cessation is a systematic step-by-step approach for addressing nicotine use within any clinical setting, whether it be a hospital, primary care, specialty care, any setting. And if we were to break it down a little bit further, I would refer you to the top of the slide, which essentially breaks down the program into two components. So this equation looks at two aspects. The first and foremost is a practice change or change management model. And this is the core of the program itself. In addition to that, we have a clinical component which ensures that evidence-based best practices are implemented in any clinical setting to address tobacco or nicotine addiction. And you'll see at the bottom that this is accomplished through a detailed OMSC work plan that goes across 6 phases. And I'll be discussing those phases a little bit more detail as we move along. But if we look a little bit closer at the clinical component, there are 5 key pillars that comprise this section. The first and foremost is the systematic identification of smoking status of all patients, whether they're tobacco users, whether somebody who vapes. We want to know if somebody is a current user or perhaps they have recently quit and require support in the near future as well. The second is to have a standardized way of documenting this information to ensure we're capturing it correctly. We know who's in our walls, which patients we're seeing, and learn a little bit more about them. And in any aspect and interaction of smoke cessation encounters, we want to ensure that this is documented. The third is ensuring that we provide strategic, unambiguous, non-judgmental advice to quit smoking, along with the offer of support. And that includes the first-line pharmacotherapy to ensure that the patient is set up for as much success as possible, depending on their preferences and depending on their needs. And last but not least, as we heard earlier from Dr. Mir, extremely important, we need to ensure that long-term follow-up is set up right from the very beginning. We know that relapse rates are extremely high with smoking and nicotine addiction. Therefore, it's extremely important to ensure that we have a strong follow-up system set up right from the get-go. When we look a little closer at the change management component, there are 3 main areas that we look to transform. The first and foremost is the institutional practices, which then leads to creating professional behavior changes in the way that healthcare practitioners support their patients and provide that intervention to those, and in turn leads to our ultimate goal of ensuring the best possible patient care. And when we ensure that policies and procedures are embedded within an institution, and when that is matched and backed by organizational commitment and support, we ensure and influence the way in which healthcare practitioners are able to more efficiently, accurately, and appropriately support those patients with their nicotine addiction, one of the most tenacious addictions there is. So we want to ensure that all of that is in place right from the very start to lead that ultimate goal of ensuring those patients are successful. And as mentioned earlier, so here's the map Dr. Mir was referring to. The program has been operating since the early 2000s. And as you can see, there's been over 450 sites that have been implemented, or that have implemented, the Ottawa model for smoke cessation, with more than 20,000 healthcare professionals that have been trained using the model. And this has led to over 500,000 patients who have been supported in one way or another through various means to address their nicotine use. And as mentioned as well, this has currently expanded to other jurisdictions internationally as well. I mentioned briefly that there are 6 phases of implementation. I'll go over those briefly right now. The Ottawa model is a multidisciplinary approach, and it's only effective when implemented in such a fashion. So as I go through the phases, I'll describe how that works in a little bit more detail. But first and foremost, if any interested organization, whether it be a hospital or primary care site, is interested, we want to ensure that everybody has a full understanding of what the program is, how it operates, why do you even want to implement this? How is this going to help you? And we need to ensure that we have organizational buy-in and commitment from key decision makers, key stakeholders, to ensure that the program can be implemented successfully. If that is not there from the start, the program is doomed to fail, and we need to ensure that that is a key element that is there right from the very beginning. The second is the pre-implementation evaluation. With any program, it's always important to ensure that we have a baseline assessment of what we're currently doing right now before we make any changes. And so that is what happens in phase 2. We provide support to ensure that baseline assessment is completed. And then we move on to phase 3, which is where the bulk of the work takes place. This is where specifically designed, tailored implementation protocols or flow sheets are designed for each unit, each hospital, each clinic, to ensure that everybody has an understanding of key roles and responsibilities. Tools and processes are embedded in place. EMRs are set up to ensure that all of those are factored in. And we want to make sure that everybody understands what their role is, when do they do it, how do they do it, where do they document it, so on and so forth. Once that has been established, we then provide training in phase 4 to all those involved. And as mentioned, this is a multidisciplinary approach that spans the entire setting, whether it be a unit, a ward, a clinic, so on and so forth. And we need to make sure that all of those involved are appropriately trained so that way they feel confident and comfortable to be able to address nicotine addiction with their patients, whether it be through vaping, cannabis, tobacco, so on and so forth. Phase 5 is the go live date. So once everyone's been trained, we pick a date, we go live, we start implementing the program. And during this stage, approximately a month or two in, we always do a check-in. We implement a PDSA cycle, assess how we're doing. Is the program being implemented as we had hoped, as we had intended? If there are any issues, glitches, changes that need to be made, this is where we make them, and then we continue on with that cycle moving forward. And phase 6 is essentially a repeat of phase 2. So once the program has been operating for quite some time, we do a post-implementation evaluation to assess the efficacy of the program. Is it doing what we had hoped? Is it meeting our needs? Are we seeing the results? And we compare that back to phase 2. And in addition, this is where a lot of the quality improvement initiatives take place and sustainability activities take place to ensure that the program carries forward, is sustainable. As we heard earlier, we're always conducting research within these walls externally, and there's always new evidence, there's always new technological advancements, and we make sure that that is always incorporated, embedded in updating those protocols that I referred to in phase 3. So this is an ongoing cycle once the program is launched. And all of these phases are supported by implementation specialists, which in short are essentially act like consultants or coaches that guide you through those processes step by step from phase 1 to phase 6 and beyond. And they carry on activities such as supporting needs assessments. They adapt the programs to each setting. Whether one hospital is similar to another, the protocol may be completely different. And all these protocols and work plans that I was referring to are adapted specifically to each setting to make sure that they're set up for success. We provide and facilitate the training for all those involved, as mentioned, ensuring that data evaluation and reporting is completed to share the successes that are to be had with the sites, as well as any challenges that may need improvement. And last but not least, as mentioned, they support quality improvement initiatives and ongoing sustainability activities with each site to carry that forward. So on that note, I will stop there. As mentioned, we will take questions at the end, but if you want to be a dot on that map, we're welcome to work with you and implement the program. So I will now turn things over to my colleague, Sarah, who will talk a little bit more about our database and our outcomes.
Thanks, Moose. So I'm going to jump into one of the biggest tools that we use with all of the partners that we partner with, and that would be the Omsc Database. When many of you, if you've heard of the database, may have heard it called TELASK before, they think that it is only the provision of follow-up, but that's only one of the functions that it has. So a major function of our database is actually the program management and program evaluation. So it collects all the data from all of the sites that we work with so that we can report it back to you. It lets us know your quit rates, the outcomes of your patients, etc., but also helps inform some of those quality improvement pieces that Moose and Dr. Mir have spoke about today. Again, as I mentioned, you've heard a lot about follow-up today, and it's one of the major pieces for success for patients, and that is provided through our database. So everybody who is partnered with the Ottawa model has the opportunity to use the database, and we take that long-term follow-up burden off of the clinics that we work with. We have a team of nicotine addiction treatment specialists who will follow patients post-hospitalization or post-clinic visit for up to 6 months. And over those 6 months, we touch base with those patients either via a live call, an automated call, or pushing of supportive messaging at very specific time points to support them throughout their quit journey, no matter what that journey looks like for that patient. As I mentioned, those are done at very specific time points that we know when relapse is most likely to take place or where they might need more support. If at any time during one of those calls, a patient indicates that they are struggling or need more support, it flags within the system for one of our specialists to give that patient a call back. So it isn't just an automated call that goes out that there is nobody monitoring. It is consistently monitored by our specialist. At the end of every phone call as well, there is the number that the patient can reach out to the specialist if they need immediate support as well. So again, it has two main functions. One, for us to support you as the healthcare providers and the sites that we work with in knowing the data and how well your program is going, but also the patients in terms of providing that very imperative follow-up over their quit journey. So you've heard a little bit about our program today at a very high level, but is it effective? What does it look like? What impact does it have? And I'll touch very briefly on that. So we did a study with the Champlain Region hospitals in 2010 to look at pre and post implementation of the program. And when we compared 6-month abstinence rates, we saw an 11% increase at 6 months of abstinence for those post implementation of the program. And 11% may not sound that big, but when it comes to smoking cessation, that's a huge jump. We wanted to also look at the impact that Ottawa model had on healthcare utilization. We hear a lot about utilization, reducing those bed days. So we wanted to look at the impact. And what we found, again, looking at our Champlain Region hospitals, we found that at 30 days, we saw a reduction of all-cause readmissions of 46%, a reduction of all smoking-related readmissions of 40%, and a reduction in ER visits of 22%. So 30 days is great, but what about long-term? So we decided in the same study to also look at 2-year healthcare utilization and risk of death. And what we saw was still a significant reduction. So again, with all-cause readmissions, we saw a reduction of 26%, of smoking-related readmissions, a reduction of 34%, ER visits 2% overall, but I think most importantly, we saw a 48% reduction in death with a number needed to treat of only 14 patients. So that's very significant. And again, we said it today, but our opinions may be biased, but smoking cessation really is a healthcare no-brainer. So just going over what we discussed today and kind of some of those key takeaway points is that at least or approximately 20% of all patients that you're interacting with are dealing with a nicotine addiction. Luckily, there are inexpensive, simple, effective interventions to help manage nicotine withdrawal and assist with that smoking cessation. When you're interacting with those patients, you should ask the right questions, be non-judgmental in your approaches, and really approach them with empathy and compassion. To know who you need to interact with and discuss smoking cessation with, you need a coordinated approach that has clear protocols, roles, and responsibilities that are embedded into the patient management and care plans. If we don't systematically identify these patients, we don't know who we need to intervene with. And finally, by doing so, you'll improve patient experience and outcomes and reduce that overall healthcare burden. I want to thank you, and we'll now take some time for questions.
Thank you very much, OMSC team. Sandra, do we have any questions in the chat to start?
We don't yet.
Any questions from the audience? I'll start us off. So folks, how are the challenges different from, oh, sorry, Mark, you go ahead.
Great overview, thanks a lot. I should know this as one of your smoking cessation colleagues, but I've never understood really how the follow-up works once someone is accepted into the quit smoking program or has accepted to participate. So they're seen here as inpatients often, or they were pre-pandemic. They are then enrolled in the quit smoking program, provided with NRT if that's appropriate. How do the follow-up calls work? Because whenever I'm speaking with a patient, I'm not seeing anything in Epic, so I don't know if the OMSC database is linked to Epic or if it's running in parallel. So I don't see the appointments, and I asked them who they're dealing with in smoking cessation. Often they don't know the name of the person, or it's a different person every time. So just trying to understand how all that works.
So I can touch on that a little bit. There are, I guess, two options for follow-up. So some patients may be enrolled in the actual quit smoking program, which Emily Serrano manages. So they would come for in-person appointments at certain time frames. So they're receiving more intensive counseling. And then there's the OMSC database follow-up. So once a patient is seen as an inpatient, they are entered into the OMSC database. So that's why you wouldn't see them in, well, you'll see the patient in Epic, but you wouldn't see the call schedules and their outcomes of the calls. That's all collected in the database. We are working on a link with Epic. I'm not going to make any promises. That is something we are exploring and hoping to be able to facilitate. So all that data is collected into the OMSC database. So I can give you an example of what a follow-up schedule would be, but it's very dependent on the profile of the patient. So we have different scenarios where a patient would fit. So it may be that they are ready to quit, but not ready in the next 30 days, say, or they're ready immediately, or they're just thinking about quitting. So depending on where they are at determines the amount of calls in the schedule that they receive. But a typical person who is ready to engage in smoking cessation activities would receive a call 3 days post-discharge, and then again at 14 days and 30 days. So we really front load the calls within that first month, because that's when a patient is most susceptible to relapse. They then receive a call every single month, so every 30 days for 6 months. Often during month 4 and 5, depending on how the patient is doing, they will just receive positive messaging. They won't actually receive a supportive call. But that is, again, dependent on how the patient did in month 1, 2, and 3. At 6 months is when we collect outcomes. So we determine, have they quit? Are they still struggling and need to be re-enrolled for further support, etc. So at 6 months is usually they'll receive a call, but a live call as well. And I want to reiterate, because I think a lot of people hear, oh, my patients don't like automated calls. The automated calls aren't working correctly. They don't find them supportive. So I want to reiterate that behind those automated calls, there is a person still. So the patient receives the phone number at the end of the call if they want to call somebody. But if on that call they say they're not using their medication, they didn't quit when they indicated, or that they're struggling at all, that flags one of our specialists to call them back. So I really want to stress that point, because I think often people think they're just robo calls that go out with no monitoring happening behind that. So I hope that helps answer your question.
Thanks, Mark, for asking that question, and Sarah for a great response. And if it's helpful, Mark, too, we can pass on the OMSC number to Jen to share with everybody, so that clinicians are aware what number, and they can pass that on to the patients too. So that's fantastic. Any other questions? I have actually questions. So how would you say, folks, are the challenges from implementation different when you're talking about hospital sites versus primary care? Some of the common things that you see in the differences.
So just to confirm in terms of challenges that we see, okay, perfect. So when it comes to implementing in a hospital versus a primary care, we're talking about a substantial difference in the size of the organization. And the larger the organization, the longer it takes to get consensus, the longer it takes to get approve it. On average, I should say. There are, of course, other circumstances where this isn't the case. But in a primary care implementation, for example, there is a smaller group. When we work with an organization, we establish a task force. So someone from each discipline, a physician, a director, a manager, so on and so forth. That group tends to be quite small. Therefore, decision-making can happen quite quickly. and therefore we're able to move things forward. In a hospital setting, there's a higher chain of command. Sometimes that delays the process. There needs to be a little bit more conversation that takes place. It needs to go all the way up the chain of command, all the way back down. Therefore, that's one of the challenges there. Another challenge is sometimes there tends to be a little bit more turnover in staffing from a hospital perspective. And whenever we work with an organization, we establish a site contact or coordinator, if you will, who oversees the program at that particular organization. And when there is regular turnover that happens or that can happen, sometimes that is a challenge or barrier, because if there isn't anybody to replace that individual, or if the person who does did not have the opportunity to learn a little bit more about what it is they're doing or how they operate, that can sometimes impact the ability to maintain the program and sustain it moving forward. These are just some high-level challenges, but hopefully that addresses some of the questions.
Thank you so much, Mustafa. And certainly, I can, speaking from my experience with the OMSC, they're an absolutely amazing program. So please do give them a call if you feel in your facility you would like support implementing this program. It's absolutely second to none, gold standard. Okay, so thank you very much. This is wonderful.
Thank you so much, Emily, Dr. Muir, and Mustafa, as well as Sarah, for your presentation. We'll actually introduce the next group of speakers. We're going to switch gears a little bit, and we're actually going to focus on women's heart health. And in this presentation, we have Dr. Paquin, Nadine Elias, as well as Nazli Prest, and Dr. Coutinho. So Dr. Paquin is a fellow in women's cardiovascular health, clinical research, and advanced echocardiography at the Heart Institute. She's also currently completing a PhD in clinical sciences, looking into how sex impacts the association between cardiovascular risk factors and cardiovascular diseases. Dr. Paquin previously completed cardiology training and a master's degree in clinical epidemiology at Laval University. Nadine Elias. Nadine is a graduate of the University of Concordia in clinical exercise physiology and is a certified kinesiologist with a wide experience in behavioral counseling and health promotion. She is currently the Women at Heart program lead with the Canadian Women Heart Health Centre. Nadine has been with the Heart Institute since 2005. Since 2013, her focus has been to design, develop, and implement a peer support program for women with heart disease. After the program launched in 2015, she has been overseeing day-to-day activities of the program, working with a research team to evaluate it and looking for expansion opportunities nationally. Nadine is also a health coach, providing one-on-one counseling to at-risk population and help them gain the necessary tools and skills to prevent or manage their risk factors. Nazli Prest is a clinic nurse for women's heart health and hypertension clinics. She is a certified diabetes educator and working towards obtaining her doctoral degree in education. Nazli has worked in acute cardiac care, research, and the community before joining the women's heart health and hypertension clinics in 2021. Nazli is currently leading many quality initiatives directed towards improving women's heart health education and care. She is a member of the Canadian Women's Heart Health Alliance. Dr. Coutinho. Dr. Coutinho is a clinician scientist, chief of the Division of Cardiac Prevention and Rehabilitation, and chair of the Canadian Women's Heart Health Centre at the University of Ottawa Heart Institute. She's also an associate professor of medicine at the University of Ottawa. She's the recipient of numerous awards, including the AHA and CCS Young Investigator Awards, and her research focuses on the evaluation of aortic function and hemodynamics to understand the pathophysiology of cardiovascular diseases, with special emphasis on sex differences in aortic function. To pursue these investigations, she holds multiple competitive grants, including a CIHR project grant. Welcome.
Hello, everyone. I'll take my masters for the podium so everybody can hear me. Welcome to our session. I was asked to start us off today with some basic facts and the statistics that we think everybody should know about cardiovascular disease in women. So if you go out and you ask people out in the streets, what do they perceive to be a woman's greatest threat to her life or to her health? The far majority of women, and research says anywhere between 60 to 80% of women that you ask this question will say that breast cancer is the greatest threat to their health. But this is a myth. The reality is that heart disease is in fact the #1 killer of women worldwide. And statistically, it actually kills 5 times more women than breast cancer and 2 times more women than all cancers combined worldwide. We have actually done this survey here in Canada, and we have a few years ago published that only 13% of Canadian women, however, can accurately identify cardiovascular disease as the #1 killer of women worldwide. Most women still did not know that. So the bad news is that cardiovascular disease is indeed the principal killer of women worldwide, and it accounts for 1 in every 3 female deaths. But the good news is that the far majority of cardiovascular diseases can be prevented. Just about 80% of the time, there is prevention opportunity for cardiovascular disease. So on the topic of prevention, I think it's very important that everybody should know there are conventional cardiovascular risk factors. These are the risk factors that I think most people know about, have heard about: so hypertension, high blood pressure, smoking, physical inactivity, obesity. All of these risk factors predispose both men and women to have cardiovascular disease. However, they are more ominous for women. For example, just to highlight some of the things on this slide, hypertension is not only more common in women, there are more women in this planet walking around with high blood pressure as compared to men, but also is a stronger contributor to cardiovascular disease, heart attack, stroke, and mortality as compared to men. Diabetes increases the risk of heart attack to both men and women. However, in men, this increase is about 2 to 3-fold compared to non-diabetic men, and in women, this increase is 3 to 7-fold. In fact, I think many of you may have heard that women, younger women, still before menopause, are relatively protected against cardiovascular disease, which is true at that age group. But if a young woman has diabetes, that protection is nulled. So it eliminates the natural protection that the age brings to the women. The same is seen with other cardiovascular risk factors. Smoking is also more potently as a risk factor for women. Physical inactivity is more common in women. And obesity is also a more potent risk factor for heart disease in women than men. So those are some of the sex differences in the conventional cardiovascular risk factors. Then we have a whole slew of what we call female-specific risk factors. These are risk factors that men would never experience in their lifetime, but for women, they actually can contribute, sometimes independently, sometimes through other risk factors. They contribute to cardiovascular disease later in life as well. So here are some examples. Polycystic ovarian syndrome, PCOS, increases a woman's risk for cardiovascular disease by a little bit, and that's mediated through the effects, the metabolic effects of insulin resistance. I think it's no secret to anyone that a risk for cardiovascular disease for a woman increases after menopause. But for those women who reach menopause early, at the age of 40 or earlier, the risk for myocardial infarction is 95% higher than for a similar age woman that did not experience early menopause. Then we have the pregnancy-associated risk factors. It has commonly been described as pregnancy being the first stress test that a woman goes through. It truly is a significant stress to the whole body, especially the cardiovascular system. It really pushes the body to its own physiologic limits. So it is a true stress test, and it's possible that if a woman may already have some form of predisposition to cardiovascular disease, it may manifest itself first at the time of this natural stress test, which is pregnancy. So here is an example of a very potent female-specific risk factor for women, which is hypertensive disorders of pregnancy. This is preeclampsia, eclampsia, gestational hypertension, for example. Summarized here are some of the independent effects of having a hypertensive disorder of pregnancy on different cardiovascular diseases. For example, a woman with a history of HDP stands for hypertensive disorder of pregnancy, has about 3.7 times higher the risk of chronic hypertension as compared to women with normotensive pregnancies. The risk of stroke is higher by 81%. There's a 50% increase of the risk of atrial arrhythmias. Risk of heart failure is 4-fold higher in this population, and that's not just around the time of pregnancy and delivery, or just not just peripartum cardiomyopathy. It's a risk that persists in the long term. Heart attack increases by 2.5-fold, and cardiovascular mortality is 2.2 fold higher. It has recently been described that about 50 to 60% of this increased risk that women observe or experience after a hypertensive disorder of pregnancy is actually mediated by conventional risk factors. So, but the other half, the other 40 to 50% of the risk is not mediated by cardiovascular risk factors, so remain independently associated with having an abnormal hypertensive disorder of pregnancy. Other pregnancy complications, as summarized here, can also highlight a woman's future risk for cardiovascular disease. We know that gestational diabetes, placental abruption, premature delivery, having a small for gestational age baby, or a stillbirth are all independently associated with increases in the risk for cardiovascular disease later in life. Now, changing our focus from prevention to manifestation, the other important aspects that I think everybody should know are about the symptoms of coronary artery disease. And I'm going to focus on coronary artery disease from here on because it's truly kind of the bread and butter of cardiology, and it's what most of you eventually have to deal with. So when it comes to symptoms of coronary artery disease, we all studied from books, and those books that we all studied from were written based on studies, and those studies included only men. That was done, decades ago. So everything that we know about the classic manifestations of a heart attack, the classic manifestations of angina, are the classic manifestations for men because nobody bothered to study women back then. So the books will tell us that a true heart attack and true angina is a retrosternal chest pain that may radiate to the jaw or to the left arm. So if anybody has this, anybody will recognize these symptoms. However, in real life, pain can be different. It can be described as a pain that is not a pressure, but maybe a burning, sharp, dull. I hear the words indigestion and heartburn a lot. Women somehow choose in the whole vocabulary in their head, they choose to express their anginal pain many times as indigestion or heartburn. But if you ask a little bit deeper, they would tell you, does it really feel like heartburn? Have you had heartburn before? And they would say, no, it's different. But that's the word they choose to express. So pay attention to that, as that can be a sign of a heart attack. Sometimes the pain can be just in the epigastrium, or sometimes just in the neck and the jaw, or just the arms. Or in very rare occasions, there could be the heart attack can present with just shortness of breath, just nausea, or just exhaustion. But just know that the far majority of women will have some form of chest discomfort. Now, I think most of you have at some point in your careers have heard this description that while women have atypical symptoms of angina, they have atypical symptoms of cardiovascular disease. The reality is that because the typical definition of angina and heart attack were described in men, anything that is a nuance for women is described as atypical. So now the recommendation is that we do not use this nomenclature anymore, saying that women have atypical symptoms marginalizes women's health, and it really doesn't help anybody. So the most recent chest pain guidelines that were published just last October are recommending that we no longer classify chest pain as typical or atypical, and rather we do our best to try to classify chest pain as likely angina or likely cardiac chest pain. On the opposite side, likely non-cardiac chest pain. And then there's a whole gray zone in between. So we are asked to use this terminology now, cardiac chest pain, non-cardiac chest pain, and try to sort out so we avoid this typical and atypical phenomenon. And here's a study that to me was always a great eye opener when I saw it presented at the ESC a few years ago. And it really addresses this issue of typical and atypical. So this was the Hermes study, is a study of patients that were referred to the cath lab. Most people referred to the cath lab either have chest pain or having a heart attack for the most part. What they did is they recorded the conversation of the patient with the doctor, analyzed that conversation through natural language processing, and put it in a computer with artificial intelligence for the computer to interpret the conversation. So if we listen to the computer would tell you that first, 90% of both men and women have chest pain. So this business of saying that, oh, women with heart attacks, women with angina, they don't have chest pain, they have other symptoms, it's wrong. Majority of women have chest pain, just like men. Then the other important part is that when the computer analyzes the symptoms that were being expressed in the conversation, they identified 9 clusters of symptoms, and these 9 clusters of symptoms were identical for men and women. So what is the moral of the story here? The moral of the story is that if you let a computer listen to the patient, the computer will say that women and men present the same way with similar symptoms. But if you have a human being listening to the patient, the human being will often label the men as having typical symptoms and the female as having atypical symptoms. So it's a really good exercise for us to understand, and also remember that we all have biases. None of us are free of biases, and we carry these biases with us, and we have to always be checking them to make sure that we're listening appropriately and providing appropriate care. The other important study that I wanted to show to you about the presentation of myocardial infarction is this one. Again, people talk about women have different symptoms, not having chest pain. As you can see on the top line here, the proportion of men and women presenting with a heart attack with chest pain was the same. So that's not different. What truly seems to be different between men and women, as you can see in the bottom, is that women are more likely than men to have 3, 4, or more additional symptoms to the chest pain at the time of the presentation. So for example, a man will come in with chest pain and shortness of breath, and the woman will come in with chest pain, shortness of breath, fatigue, palpitations, exhaustion, and syncope. There are more things. So it's a more florid syndrome, which makes it harder for the woman to realize all of these things she's feeling is a heart attack. Makes it also harder for the providers on the other end to hear all of these symptoms and then find a heart attack in the middle of all of it. So this is truly the main difference between the two sexes when it comes to presentation of MI. The other thing I wanted to discuss today, and we discussed this in my clinic this morning, is that people can have different anginal triggers, and this is more common in women. We all learned that the classic trigger of stable angina is exercise, is a pain on exertion that relieves with rest or nitro. And in real life, what we can see is that chest pain, anginal chest pain, due to decreased coronary blood flow, can indeed be caused by emotional stress and anxiety. And this is most common in women than men. Very often, it gets attributed to being, all in their heads, being because of the anxiety and depression, which can be the case, but is often not the case. And one study that elegantly demonstrated this is this one shown here, where they took patients with a recent myocardial infarction. They had similar rates of revascularization, but women had less severe epicardial coronary artery disease as compared to men. Then what they did was a mental stress test. They took the patients and they said, okay, you have 3 minutes to prepare a 5-minute speech about whatever topic. It's enough to produce a minimal amount of mental discomfort, nothing in comparison to real life, but still a little bit uncomfortable from a mental health perspective. And then once they provoked this mental stress, they did a nuclear cardiovascular imaging and look at the perfusion of the myocardium. And what they found is that women were 3 times more likely than men to experience documented ischemia on nuclear stress testing as compared to men in response to the mental stress stimulus. So this is not just all in her head. This is a true physiology, brain-heart connection. It happens all the time. We saw one in clinic this morning. Pay attention to it if you listen to it, if you listen to this story. And now moving on to treatment and prognosis. That's how I'm going to finish off this part of the talk. Even though women benefit just as much from secondary prevention strategies as compared to men once they've already had an event, as you can see in this table, and this is only one of many studies, women are less likely to receive life-saving secondary prevention strategies as compared to men. They're less likely to receive aspirin, a second antiplatelet agent, a beta blocker, or a statin, for example. All of these things they would benefit from, but they're less likely than men to receive these therapies. When we look at cardiac rehab referral, we know cardiac rehab is very important in restoring mental and physical health, restoring contribution to community, and cardiac rehab is associated with decrease in hospitalization and cardiovascular mortality. Despite this, when you look at this meta-analysis, anything to the left of the line of unity here in this forest plot means that women are less likely, and anything to the right means women are more likely. And when you pull all the data from the research studies, you will see that women are on average 32% less likely to be referred to cardiac rehab as compared to men. This is at the referral already from the get-go. They're less likely to be referred. And even though they would benefit just as much as men. Then we look at prognosis, perhaps as a direct result of receiving less secondary prevention, receiving less cardiac rehab, women are more likely to be rehospitalized in the first year after an MI. In this Kaplan-Meier curve, on the left, on the y-axis, you have the rates of rehospitalization. The gray lines are women, younger and older, and in the black lines are men, younger and older. And regardless of the age group, you can see that women are more likely than men to be rehospitalized at 12 months after a myocardial infarction. And unfortunately, 30-day mortality remains higher in women as compared to men. Here on the left, we have mortality rates, and then on the x-axis, we have time. So these are the temporal trends in mortality rates, which thankfully have come down in both men and women. But even at the last analysis, women, both black and white, so those are the two colors here, black and white women, still had higher 30-day mortality rates after myocardial infarction as compared to black and white men, which is perhaps directly related to later presentations, less intensive acute and post-acute care, etc. So with that, after laying out all these facts for you, I'm going to pass it on to my colleague, Ms. Nazli Paras, who present a few more details about women's heart health and our clinic. Thank you very much.
Hi, everyone. I'm just going to start sharing my screen. My name is Nazli. I'm the nurse with the Women's Heart Health and Hypertension Clinic. I'm just going to give you an overview of our clinic, and then Dr. Packin will provide more details about the conditions we see. I will start with a quote from one of our patients who said, listen to your body and investigate your symptoms with your doctor if you're feeling something new, like any symptoms you had before your heart event. As Dr. Coutinho mentioned, there are some similarity between the risk factors between women and men, diabetes, smoking, high cholesterol, physical inactivities, stress, anxiety, and hypertension. But then women are vulnerable to heart disease due to menopause, pregnancy-related complications, giving birth to underweight baby, preterm delivery, potentially being on certain birth control medications, and having polycystic ovarian syndrome, and many more that she mentioned. Another quote from another patient was that realize that women's cardiac health is understudied and that some professionals may not recognize a woman's cardiac symptoms. So in our clinic, we have 3 doctors, Dr. Coutinho, Dr. Packin, and Dr. Gerua, and I am the nurse for the clinic. We see patients with SCAD, which is a spontaneous coronary artery dissection, myocardial infarction with non-obstructive coronary artery disease, which is MINOCA, and then we have angina with no obstructive coronary artery, so INOCA or ANOCA. And then we also see women for the evaluation of cardiovascular risk in women with hypertensive disorders of pregnancy or gestational diabetes. So usually I see the patients and then do their pre-assessment, and then after my visit, they will have a visit with a doctor. I try to get as much relevant information from the patients as possible, and I try to kind of help them to be able to connect the dot between their symptoms or the events that are happening in their life and their heart condition. So then they're more likely to share as much information as possible, because even though they might think that they are not relevant, a lot of the information they share are actually relevant to their heart condition. The resources and supports that are available for women's heart health. Well, in our clinic, we have the Women's Heart Health Patient Education Group, which started actually in May of this year. We had Dr. Peckin presented on May, and then Dr. Coutinho presented in June, and we're taking a break between July and August, and then resuming again in September. So every month is a different presenter. We will have presenters presenting, and then following a Q&A for patients to be able to ask questions from the provider that presented. The session is first Thursday of the month between 5 to 6 p.m. The next one is coming up is September 1st. I believe Amy shared with you guys that anybody from anywhere can attend these sessions, and I think it would be a great opportunity for anyone who would like to attend the sessions. You can just join in and see what we provide, and you can feel free to refer any of your patients from anywhere, because the information we share will be applicable for anyone. And the information about the events are on the calendar, and I believe Sandra shared that link. She might be able to send another one as well, so everybody knows where to go to access those events for patients. Of course, we have the cardiac rehab program that many of our patients are benefiting from that. And then we have the Women at Heart peer support program and the Cardio Prevent Postpartum program, which many of our patients are benefiting from that. And Nadine will explain those after a little bit later. Then we have Heart Institute Women's Heart Health Education Day for our staff that is coming up in October 13th. So this is our first Women's Heart Health Education Day that we are having for the staff, and hoping anyone who would like to join and learn more about it will be there. So stay tuned, you will hear more about it later. And of course, we have the Women's Heart Health booklet that is ready to come out at some point. It's still in under review, and hoping it will come out soon to be released to everyone. And this is my email address. If you need to connect with me, feel free to do that. And I will now send it back to Dr. Peckin, who's going to talk more in details about our clinic. Thank you so much.
Excellent. Thank you, Nazli. So it's a real pleasure. We have a great team in the Women's Heart Health Clinic, and I'm one of the fellow trainees here to become specialized in women's heart diseases. So just a few words to explain to you what are the different diagnoses that we treat in the Women's Heart Health Clinic. As Nazli's mentioned, coming soon. In just a second. just a little further. Yep, exactly. Excellent. So as Natalie's mentioned, we chose to concentrate our efforts on 4 main categories of health issues that we think we can bring the most to women. So the first category is spontaneous coronary artery dissection, also termed SCAD. So SCAD is actually a tear that occurs spontaneously within the wall of one of the arteries that feed the heart. And when the blood accumulates inside the wall of the artery, it accumulates to the point that it causes obstruction to the blood flow inside that artery. And it leads to a heart attack because there's no more blood flow going to the region of the heart muscle that's being fed by that artery. However, it's a type of heart attack that is not related to traditional cardiovascular risk factors such as smoking, cholesterol, diabetes. It also represents about 4% of all myocardial infarction cases. And what's important to us is that more than 85% cases of SCAD actually occur in women. We unfortunately are not able to predict at this moment who will go on to develop a SCAD and who won't. We've identified certain risk factors such as hypertension, pregnancy, fibromuscular dysplasia, which is a weakness inside the artery of the wall, and we've also identified triggers that can lead to the occurrence of SCAD, such as a very intense physical exercise or intense emotional stress. Unfortunately, about 10 to 15% of women or 10 to 15% of cases of SCAD can recur, and about 60% of patients with SCAD will go on to have residual chest pain after their episode. So it's very important for them to have follow-up and to be also involved within the rehab program. And the goals of our treatment will be mainly symptom relief, trying to prevent recurrence of SCAD, although scientific data in that field is still scarce. And we also treat the consequences of the heart attack. The second category that we treat is MINOCA, so myocardial infarction with non-obstructive coronary arteries. So a classic heart attack will occur, well, classic, what we've all learned in school is that there's a cholesterol plaque that breaks, and the release of chemical products inside the blood will cause an acute blood clot to obstruct the blood flow inside that artery. However, in many cases of heart attack, we cannot find that obstruction. So we cannot find that cholesterol plaque that's blocking, and we cannot find that blood clot that's blocking the blood flow. There are different causes that can explain that. The blood clot may have been eaten by the body already by the time we do our tests. SCAD is another potential cause of MINOCA. Vasospasm or microvascular dysfunction. These are all causes that can lead to a heart attack without obstruction in the coronary arteries. MINOCA represent about 5 to 15% of cases of heart attacks, and women are twice more likely to have a MINOCA when they present with a heart attack. So our role in the Women's Heart Health Clinic is to investigate to try and diagnose the underlying cause for that MINOCA, and this will help us administer the proper treatment according to the diagnosis. The third diagnosis that we follow is angina with non-obstructive coronary arteries. So we know that angina is a symptom that's provoked when there's a portion of the heart muscle that is transiently not receiving blood flow or the oxygen that it needs to work, but not for a duration that's long enough to cause a heart attack. And in the context of INOCA or ANOCA, similar to MINOCA, we're not able to find cholesterol plaques or obstruction in the arteries that explain the symptoms, that explain the decrease in blood flow. So again, different causes can be involved in these cases. And one of these causes that we're trying to find in the Women's Heart Health Clinic is microvascular disease or dysfunction, which is when the blood flow is altered, but not in the large arteries, as we can see on the coronary angiogram, but more so in the capillaries, which are the smallest artery of the heart. And these arteries, were not able to image them with the coronary angiograms. So we need other tests to do this diagnosis. We will make this diagnosis, or we'll make the diagnosis in the context of INOCA, ANOCA, using different tools, and also using advanced technology in the coronary, in the cath lab center to take measurements and calculations in the arteries and try to see how the blood flow is going on in the smaller arteries of the heart. So about 2/3 of women with angina do not have obstructed coronary arteries. INOCA or ANOCA is associated with an increased risk of hospitalization for chest pain, increased need for meds, increased risk of heart attack and mortality. So finding the right diagnosis helps in finding the right treatment as well. And lastly, we also provide service to evaluate the cardiovascular risk in women with hypertensive disorders of pregnancy or gestational diabetes. Like Dr. Coutinho mentioned earlier, we know that hypertensive disorders of pregnancy are associated with an increased risk of cardiovascular disease. And we also know that this risk is also increased in patients with gestational diabetes, preterm birth, low baby birth weight. So our goal in the Women's Heart Health Clinic is to perform early screening for other cardiovascular risk factors that we can act upon. We believe these women are a good target for early preventive measures, and we also provide counseling regarding non-pharmacological and pharmacological strategies to lower their cardiovascular risk in the future. And we think it's a great opportunity to raise awareness about women's heart health for these women, but also for their family, for their healthcare professionals, and so that they can spread the word around them that heart disease is not only a disease of men. So just to conclude, why the Women's Heart Health Clinic exists? Well, because cardiac disease is different in women compared to men in regards to their risk factors for heart disease, the impact of these risk factors, their presenting symptoms, and because certain diseases do affect women more than men. So I pass it on now to Nadine Elias, who's gonna tell us more about the different resources at the Women's Heart Health Clinic.
Thank you, Dr. Paquin. So good afternoon, everybody. Hopefully everybody's enjoying their afternoon and they're enjoying the day. So I'm Nadine Elias, the program lead for the Canadian Women with the Canadian Women Heart Health Center for the Women at Heart program, which is a peer support program for women with heart disease. I have the privilege at the Canadian Women Heart Health Center to work with a great team of professionals under the supervision of Dr. Carrie Mullen, who's the director of the center. In the next few minutes, I was tasked to present to you some of the program and services that we offer through the center to help women through their heart healthy journey, but also to help increase the awareness of women and heart disease, as well as increase, the knowledge in terms of women and heart disease within our medical field. So at the center, we strive to change the women's heart health landscape across Canada by delivering local as well as national initiative to improve the outcomes for women with risk for heart disease, but also women living with heart disease. We conduct women-specific research at the center. We offer educational programs to women, as well as offering education to healthcare providers. And we do some advocacy activities to help increase the awareness of women with heart disease. Here's a quick overview of the different programs that we offer. So you heard already about the Women's Heart Health Clinic. We also have a virtual care program that allows us to help patients to self-manage themselves virtually online with a lot of resources through our health library, but also including tracking tools that will help them through their journey. We also have our CardioPrevent Postpartum program, which is a prevention program for women who have not developed heart disease but are higher risk for heart disease to help them through changing lifestyle by having health coaches supporting them over a year term. We also have the Women at Heart peer support that I'll dive in a little bit closer because that's kind of my little baby. We'll talk about more in a second. We have the Community Advocacy Toolkit, which is an online toolkit that anybody within the community who has the women's heart health topic at heart that could take the training and be able to offer presentation within their local community to increase awareness. We also have the Canadian Women Heart Health Summit, as well as the Alliance. So the Women at Heart program is a peer support program for women who have had a heart event that is also led by women who have had heart disease. We train them, people who are interested, women who are interested in supporting others here at the Heart Institute to help them through their journey. With the pandemic over the last few years, the last 2 years, we were able to get our training to be a virtual training and actually reach nationally across Canada to train women to offer that program locally. And the program is offered virtually as well as in person. So it's supporting women through their journey by offering them emotional support, educational support, as well as appraisal support. The way the program runs is that it's over a 4 months period. There's 10 sessions of a curriculum that is built on each other. The sessions build on each other. 2 hours on a weekly base as well as bi-weekly base. The group meets. There are about 6 to 8 women within the group, and they go through supporting each other through their heart healthy recovery. The groups are closed groups, so once they start together, the groups stay together to create a bond and a support, a safe environment for women to come and share and talk about their experiences and also get the support that they need. All registration is done online, and anybody who finds the program online is able now to register because it is offered virtually. Since the pandemic, we were able to actually reach out to women outside of the Ottawa area because the program is virtual, and our reach in terms of outside of Ottawa have increased by 312%. So there is definitely a need. The women are looking for support. So we want to keep expanding that program and helping as many as we can. Depending on your patient's need, you know, if a structured program might not be for them or there's somewhere that they might not have access to it, we have through the Alliance, the Canadian Women Heart Health Alliance, one of our subgroups have put together a peer support heart hub. So it's a registry of different peer support that exists across Canada, where people could find the information on where the group, how the group runs. So it is a resource now that is available online for patients to look up resources within peer support resources within their community, you know, or online as well. All the information I'm sharing with you could be found at yourheart.ca. That's our website that have all our initiatives as well as programs that we run at the Canadian Women Heart Health Centre. Just quickly going over some of the other initiatives that might be of interest to you. So we do have the Canadian Women Heart Health Alliance. So this alliance is a network of over 116 experts that comes together to disseminate and transform the clinical practice and the different strategies to transform women's heart health. So basically, there is 4 major pillars of the alliance. So we focus on knowledge translation and mobilization, education training, advocacy, as well as the health system and policy. One of the activities that had started in 2019 of the advocacy working group, they've launched the Wear Red Canada campaign. So every year on February 13th, we celebrate women's heart health. We put the word out, we try and increase awareness, and anybody could participate and be involved. You could, you know, conduct presentations, you could talk to your family about it, you could wear red and post your pictures. So there's always a way to try and put the word out and increase awareness for women's heart health. The training and education group have developed the Women Heart Health Education course that includes 9 accredited curriculum, and you could see them here. That covers different topics, and it is geared toward healthcare professional as well as trainees within the emergency medicine, general internal medicine, as well as cardiology. And it is available online, and it's free of charge, so you don't have to be paying anything for that. And people could get up to 7 hours accredited for doing the toolkit. We also have the Atlas. So the Atlas, it's through the Health System and Policy Group that have put it together, the Atlas, which it's published in the Canadian Journal of Cardiology. And so far, we have 6 chapters that have been published, as well as a video recording with each one of them to be able to promote them. And they are available on our website for people to increase their knowledge on the different topics when it comes to women and heart disease. And there's also an infographic with each one of the chapters that allows to have a good visual of the status of women and heart disease. And to wrap it up, make sure that you don't miss the upcoming opportunity to participate in the Canadian Women Heart Health Summit, which is one of a kind. It is the only event that allows people from across Canada, practitioners, as well as advocates to come together and talk about what is the knowledge gap and what is needed to be done more when it comes to women heart health, as well as new research that are in the work. It's an accredited opportunity for knowledge exchange for a variety of stakeholders, and it helps us build success on previous years. So since 2016, we've been running the summit. So we are on to our fourth year that will be hosted in Vancouver. So, you know, mark the date, April 28 to 29 of 2023. And question, I guess, for any of the presenters.
Thank you very much. That was awesome. Sandra, questions from the chat first.
Yeah, we have one for Dr. Coutinho, and this one's from Carolyn. Her question is, to clarify, is the lower number of women getting post-cardiac support relating to women declining due to busy home/lifestyles compared to men, or is it truly not being offered to women as often? So in essence, are women declining post-cardiac supports?
Great questions. So I think this pertains to cardiac rehab. So there are deficits, there are female-specific deficits at all levels. So women are less likely to be referred in general. This is literature, if you look, you know, worldwide. At the Heart Institute, our referral rates, I'm happy to say, are very similar for men and women. But in general, women are less likely to be referred. Then, among those who are referred, women are anywhere between 9 and 32% less likely to enroll. And then among those who enroll, women are less likely than men to engage and complete. So there are really deficits at all levels. There are potential solutions for these deficits at all levels. So at the referral point, we shouldn't be relying anymore on a person or just a doctor to actually go and make that referral. Automated referral systems have really helped decrease referral biases and also increase referral rates for both men and women, especially when there's a liaison to also help with the automated referral. And this is something that we do use here. So that's a solution for the referral. Then I think your question had more to do with the enrollment and why are women not enrolling. Is we actually do survey our patients here at the Heart Institute from time to time and have asked them again and again, if they declined cardiac rehab, why was it that they declined? And every time that we ask this question for both men and women, they tell us that the number one reason they decline is because their doctor didn't tell them it was important. So I always tell this to my residents when I'm rounding and etc. Because when we discharge a patient from hospital, we're very good at saying, oh, you got to take or do antiplatelet therapy, you got to take your statin and everything else, but we don't say, when you get a call from cardiac rehab, you have to enroll. So they hear all these things they have to do, but they don't hear you have to enroll in cardiac rehab. So, you know, they don't feel it as important. So that goes for both men and women. And I think all of us can play a role in this as we are seeing our patients, regardless of our role in the healthcare system, to inform them of the important benefits of the cardiac rehabilitation. And what I was told by Jen Harris, who's the manager here at the Heart Institute's Rehab, is that interestingly in our region, when it includes smaller cities, smaller hospitals, smaller communities, I was told just a moment ago that actually women enroll a little bit better than men. And we actually know from our own experience that even here at the Heart Institute, women are less likely to accept and enroll as compared to men. But if we look at our programs that are offered in the community, such as a HeartWise exercise program for patients that wish to prevent or delay heart disease, you know, 80% of those people exercising in the community are women. So there's something about decentralizing and having more flexible options that may help us also solve this female discrepancy in rehab enrollment. So long answer to a small question, but it's a very loaded question. So lots of potential for improvement there.
Thanks, Dr. Coutinho. We're going to take one more question from our virtual audience. This one's from Sarah. This is probably directed best for Nadine. The question is, if a person lacks a primary care provider and is having trouble getting a referral for the Cardio Prevent postpartum program, is there a possibility of self-referral?
Unfortunately, the answer is no. There is no place for the self-referral in the cardio prevent because we don't offer any medical follow-up when it comes to the cardio prevent. It's based on health coaching. So we want to make sure that when we have somebody that is referred, that they are attached to a physician, that if there's any challenges or any changes in medication or in their symptoms, that we're able to go back to the physician. So ideally, what we recommend if they don't have a physician is even just to go to a walk-in clinic, and be able maybe to get the referral through that, but they have to be attached to a doctor in order for us to do the follow-ups if there's any changes in symptom or medication.
Great, thanks very much, Nadine and Dr. Coutinho and Dr. Paquet and Nasli, an absolutely amazing presentation. And remember, there's going to be a whole day of women's heart health education coming up on October 13th. Sandra is kindly going to be sending out all the invitations and information for that. And as well, remember that with all the virtual offerings, you can offer your patients our new education class and the Women at Heart program as well. So please do take advantage of these. So thank you. Okay, so we're going to take a 15-minute break and we'll be back at 2:30 to talk about cardiac rehabilitation and heart failure. So thank you. Everybody's back. So our next presenter is Jennifer Harris, and Jennifer is going to be talking to us about cardiac rehab and virtual care, learnings and opportunities during the pandemic. So Jennifer is a registered physiotherapist, and she is the manager of outpatient cardiovascular rehabilitation and regional outreach programs here at the University of Ottawa Heart Institute. In addition to supporting best practice cardiac rehab delivery by the multidisciplinary team here, she also directs HeartWise exercise, a community exercise model, and facilitates cardiac rehab delivery in Champlain region. With a passion for knowledge translation, Jennifer is an active research collaborator, regional partner, and committee member for various organizations supporting the care of cardiac rehab and community exercise programming. Okay, Jennifer, I'll turn it over to you.
Thank you, Bonnie. And it's so wonderful to see so many familiar names and some faces, certainly from our regional cardiac rehab programs, and of course, as well from across the province and the country. So very exciting to see you all here today. Okay, so my goal for the next 30 minutes in giving you a quick update is really to focus on a couple of changes we've undergone here at the cardiac rehab program at the Heart Institute. So first of all, I'll give you some updates in terms of our risk factor profile based on some new guideline releases. We'll talk about some of the updates we've made to our programming because of the pandemic, focusing on some of those virtual changes. I'll talk a little bit about some of the results, and of course, we'll share some resources with you. So first, before I get started, I do want to reflect that the work that I'll talk about within this presentation is really a reflection of the amazing cardiac rehab team that I have the privilege of working with here at the Heart Institute. It's an amazing team of dedicated, professional, knowledgeable healthcare providers. So just to get us started in the conversation, I wanted to draw your attention to this article that was released a little over a year ago that really talks to the changing landscape of cardiac rehab. As you all know, cardiac rehab started off as a program of early mobilization and was really shown to reduce mortality quite significantly, as you heard from Tammy this morning. But it's really evolved over the years to be a program more of looking at the patient's overall well-being and involving many disciplines, and really being a program suited for people with multi comorbidities and a program of chronic disease management. So, and particularly related to our talk today, the article highlights that rehab evolution has also grown from being effectively offered in centers with where we have supervised exercise sessions, then being shown to be effective via home and community delivery. And certainly lately through the pandemic, it's also being shown to be effectively delivered virtually as well, using different technologies. Also included in this conversation is the concept of starting with cardiac rehab at the prehab stage, which we talked about earlier today as well. So in keeping with the theme of multi-morbidity management and related to what you just heard this morning from some of the new guideline updates, I'm going to talk about some of the changes to our risk factor profile that have been based on new guidelines recently released. So certainly ACSM released some new guidelines a few years ago. We had the obesity management, obesity guidelines from Obesity Canada that you heard about this morning from Cassidy, as well as Hypertension Canada put out new guidelines, and the CCS in 2021 released new guidelines for the management of dyslipidemia. So all these put together led to an evolution of our risk factor profile that we provide patients. And certainly this risk factor profile does form the cornerstone of the intervention for cardiac rehab that we provide here at the Heart Institute, and of course in cardiac rehab programs in general. So I've used the arrows to highlight where we've made the changes. The first one I'll draw your attention to is the physical activity. So our previous risk factor profile had the target of 30 to 60 minutes per day, aiming for 200 to 400 minutes per week. So again, based on the most recent updates from ACSM and also reflecting that changing landscape of the patients in our programs, many of whom have multiple comorbidities and are really starting with functional capacities that are quite a bit lower than we'd seen in the past, making that target of 200 minutes perhaps seem unrealistic. So we wanted to, well, again, based on guidelines, we lowered that early threshold from 30 down to 20 and certainly changed the wording. So we're now really acknowledging that some exercise is better than no exercise, and of course, more exercise is better than some, but really giving permission and encouraging patients to do that little bit instead of setting them up for a very high target. Blood pressure also we've made a change to. Again, the new guidelines now favor measurements taken at home. So our wording now includes the difference in thresholds from a home blood pressure. So it's a little bit lower if you're taking it home, down to 135 on 85. And of course, we have kept the same target for those people with diabetes as previous, which is below 130 on 80, either at the doctor's office or at home. Another big change came related to obesity. Again, in the previous risk factor, that first target or risk factor was referred to as BMI. And again, as you heard this morning, we're really trying to get away from linking so many things to BMI. So really we called the risk factor as it is, which is obesity. And the target value teaches about best weight. So rather than having an actual weight that's in the target, it talks about best weight and teaches that this is the weight you can maintain when living the healthiest life you are able. So I included our whole risk factor profile here. Oops. Not advancing anymore. There we go. I included the whole risk factor profile just so you could have the whole picture, but we didn't have any updates on the next two sections. The last update came in relation to our LDLs, which is there were new guidelines released, as I noted. And so we now include the fact that for those without coronary artery disease, PAD or diabetes, there is now a new threshold of below 2 millimole per liter. So that's another big change. So you'll hear in a moment a lot of the different virtual strategies that we have implemented at the Heart Institute, and one of them is a educational class teaching about this risk factor profile. And so it is a Zoom session that we offer through our MyChart, but it's also available in a recorded version on our website. And so again, that's something that all our patients can access, but of course, any of you or your patients can also access. And it's really just a 45 to 60-minute session that goes over all of these risk factors and talks about the targets. Okay, so our next learning objective was to talk about some of the virtual strategies that we added to our program over the pandemic. So starting right at the beginning of our cardiac rehab patient journey, we had to right away in the pandemic change our automatic referral process. So that's the AR. So you've heard quite a bit about this today. We're very proud of our automatic referral process here at the Heart Institute. But prior to the pandemic, it was an in-person process where nurses visited patients in the hospital at their bedside and spoke to them about cardiac rehab. But of course, many times they miss this opportunity, patients leaving on the weekend or leaving after only a few hours, or just not being too busy in their medical care to see an in-person nurse. So for many reasons, but most certainly the pandemic, we shifted this work to being completely virtual, where the nurse uses the electronic medical record to review the patient's files, ensure that the person is appropriate, i.e. Not unstable. As you heard this morning, we have a very broad eligibility criteria, and the really most important thing is that they're medically ready to attend cardiac rehab, and then we'll triage that through our triage coordinator. You also heard one of the changes we made related to that process that we started in February of this past year, February 2021, where we have the physiotherapists involved in our surgical patients' care enroll them directly into cardiac rehab or refer them directly to cardiac rehab. But along with that referral comes the education about what cardiac rehab is, that it's part of their care map, and also they are actually discharged from the hospital with their actual intake appointment. So that process itself has certainly increased our enrollment rate. We were sitting at around 49% in 2019, and I've gone up to between 53 and 72% since the pandemic, and it's been a higher enrollment rate for women using this process. So the new processes, together looking at the increased eligibility plus ensuring that all the patients, surgery patients, are given an intake before they leave, has meant that our overall referral volumes has gone up fairly significantly since the beginning of the pandemic. And also that combined with the fact that we also never had to close during the pandemic. Unfortunately, many of the programs in the region had to close as their staff was deployed to other areas or they were not able to provide cardiac rehab service. So those referrals that we would normally have triaged out to the region remained with us. So our referrals volume certainly went up. We were able to adapt many of our processes, as you'll hear about, and we were able to increase our intake volume as well. But certainly we still have a higher volume of referral than we do have capacity for intake. So that did lead to a wait list, which grew to a little over 3 months earlier in this year. And so we wanted to really help those patients waiting on that list. So that led to another one of our virtual adaptations, which was using these webinar style education sessions that you've heard about quite a bit today to serve those patients waiting for cardiac rehab. So this is really for anyone recently discharged for cardiac rehab. They may not yet have been referred. Hopefully they have been, but we do give them the information within that session on how they could access if they haven't been. And the goal is really to enhance that transitional care that they're already getting. Again, you heard a lot about those changes and enhancements that we're doing this morning. So this webinar really just goes along with helping that patient feel like they're continuing on in the journey of care and really adding into those that transitional care that they're receiving. So we can answer their questions that they might have from, whether it's questions related to being recently discharged or questions related to cardiac rehab. And we really hope that allows them to come to their first cardiac rehab program a little more prepared and informed so they can make best use of their time with us. So again, we're using the same method that our colleagues this morning had adapted and used quite a bit over the pandemic. So by the time we started this webinar, which was just in May, the system is very smooth, and basically it allows patients just to go in on our calendar on the Ottawa Heart website, and again we'll share that link with you, where they can just click the link to join the meeting anytime they choose. So they can come once, they can come 5 times, it really doesn't matter, and certainly there's no registration required or limits or anything like that. It's also available via teleconference, so we can reach people who don't necessarily have internet access. So again, carrying along in the patient journey, we have the referral, we have this class while they're waiting for cardiac rehab, and then we have the intake, which is where we do our initial assessment for cardiac rehab. And this has been another big change for us during the pandemic. Pre-pandemic, even for our virtual programs, our case managed home program, which was offered over the telephone, and our virtual care program, which is offered through the internet, the intakes were done in person here at the Heart Institute. Again, the pandemic forced us to change right away to 100% virtual for quite a long time, as all of you have experienced as well. And this is an area that we've decided to keep the virtual component because the patients really love it and it works very well for workflow and the staff as well. So we definitely have in-person intakes available for any patient who requests it and any patient that we feel is the most appropriate way to do that intake. And that's for sure people with hearing impairments or language barriers, but it could also be for any other reason at the patient request or provider request. This method really allows people much easier access, and certainly we've heard over the years that parking had been a significant barrier and or stressor, and that's completely removed, of course, with the virtual intake. And as you'll see in a few slides, we are still able to collect all the information we need to fully populate that risk factor profile. So our quality indicators we can collect using either self-report measures or questionnaire measures. So again, carrying along in the patient journey, once they've gone through intake, we strongly encourage all patients to access their cardiac rehab education via our virtual education series. So again, this was something that we found when we moved our care early on in the pandemic to 100% one-to-one, as of course many of you had to as well, we realized this was one of the gaps. So prior to the pandemic, we had been able to offer education by our wonderful team of healthcare professionals, our registered dietitian, our psychologist, our social worker, our vocational counselor. They were all involved in providing their discipline-specific education in workshops in our auditorium, in formal groups, and of course also in informal groups at the ends of our exercise classes. So not only did the patients get that education directly from those healthcare professionals, they also got to experience it with their peers and all the good stuff that comes along with learning beside your peers. And so again, in an effort to try and both have that education delivered by the healthcare provider, as well as have patients being in that group setting where they can learn from each other, we launched a group education series through Zoom. And this was, again, something that many of you have had success with over the years as well. And so we were fortunate enough to learn from some of you who went before us. But we decided to go with an 8-week series that cohorts our patients together so that they stay together through the series and, again, benefit from that peer support along the way. And so we run about 7 cohorts of anywhere from 12 to 20 patients at a time each quarter approximately. We have the series available for coronary artery disease as well as for heart failure, and you'll learn more about that heart failure program in the next session. Otherwise, you can see the topics that we speak to at the bottom of the slide, and this will be another one of the resources that we'll share with you in the links because, of course, these are now all recorded and our patients can access them as well as you and your patients either on demand or as well our patients can access them through Zoom through the MyChart patient portal, which does require them to have MyChart access. And just as an aside, we do in cardiac rehab have majority over 85% of our patients using that patient portal. So it does really facilitate this type of education. But it is also available via telephone. So we open up a teleconference line for each session so patients can join. So now I'll just switch gears a little bit and talk about the program options we have at the Heart Institute right now. And so this is just an overview. I'll go through each of these, but really the key points are that for all the options I'm about to describe, all patients have access to the full cardiovascular rehabilitation team and all the services that we have to offer. Tammy touched on many of those this morning, but you know, all patients have access to everything. And certainly we do try and enroll all the patients into that virtual education series. And again, they can choose to do it live or on demand. So we certainly have, we are very happy to have on-site exercise back again. It has been on and off during the pandemic based on the shutdowns, and certainly we get our direction through IPAC at the Ottawa Hospital. So, you know, they really give us a direction on open or close, and then when we're open, what rules in terms of distancing, et cetera, that we need to follow. So just to start off with that, our patients are currently coming in groups of about 10 to 15. The most important aspect is that we maintain the 2-meter physical distance. Of course, all patients and staff at the moment are wearing PPE, including masks and eyewear for the staff. And we heavily encourage hand hygiene, as we always had, but there are many stations with Purell and hand sanitizers around to encourage regular use and cleaning of the equipment that's used. So right now, our on-site program is once a week. So that's another big change from pre-pandemic where we had been twice a week. So the idea is that they come in once a week for their exercise class and they get that second time a week contact through the virtual group sessions. We are offering classes at all of the levels that we had pre-pandemic, so low, intermediate, high. We have interval classes, and we have a specialty Nordic walking class. So we offer programming Monday to Friday, mornings and afternoons. We have an evening class or 5:15 and a reasonably early class. We are finding patients aren't needing that early morning class as so many more are no longer commuting into work. So it is a different patient population and they have different needs than we had before. And I envision that we'll continue to adapt as we continue to evolve in this post-pandemic time. So I already noted that these programs are offered in conjunction with our virtual education and they have access to all the other team members. New also during the pandemic, and this is one of our more recent adaptations, is our virtual exercise program that's live and supervised. So again, this was something that other programs before us were able to do quite early on in the pandemic. We only got started just last fall, starting with a pilot program of delivering exercise bicycles to people's homes and doing a very small project where we were providing supervised indoor cycling sessions. And then we started in October with a live supervised chair-based class that really targets our lower functioning patients. So this is really wonderful in removing barriers for people. They're joining us from their living rooms in their chairs. And then in January this year, we added on a moderate intensity sort of aerobics type style class. So these are all, again, through Zoom, supervised live, but use exercise videos that are played during those classes. So patients can be accessing those videos, of course, all the other days of the week, which is what we encourage. So those are offered once a week also for 8 or 10 weeks, and again, include access to all our other services. So we also continue to have some of the other program or all of the other program options we had pre-pandemic. And I include here the virtual care program, which is an online program offered through a very interactive portal. Patients' smart devices can load their information up to the platform, so that can be part of a conversation with the health coach. We have our case managed home program that's typically offered through the telephone because patients opting to that stream often aren't choosing those other things that are available through Zoom and often don't have MyChart access. And we also still have our brief program, which is where for patients who have a higher physical and health literacy and lower cardiac risk and really just need, more of a one-time consult to review those risk factors that they have and be given a very specific exercise prescription to get them back on the road to recovery, as well as our Francoform program, which is a case managed home program specifically for Franco-Ontarians and does include primary as well as secondary prevention. So I did promise a little bit of results, and so just in the interest of time, I'll keep it very brief, but I already noted that our referrals have gone up significantly since pre-pandemic, as well as our intakes. The average age of our program completers is 66, and you can see in the pie chart the program options that most of our patients are choosing. And again, this was for the year of 2021, so I expect it to change quite a bit over the coming years as hopefully more patients come on site. But certainly in 2021, we had a little more than half choosing that case managed model, either straight up or in combination with our on-site, which we called our hybrid, which is what we had available in 2021. So as for, so the dark blue is the modified case managed program, and the rest are fairly evenly split, as you can see, between on-site, brief, Francoform, and the virtual care program. I noted earlier on that we are able to collect the outcomes that we need to populate that risk factor profile, either virtually or through questionnaire. So you can see the list of those that we collect at intake. And I can just briefly share that in terms of those who completed the follow-up questionnaire in 2021, we we do see a modest improvement from baseline to end of program in most measures. There are only a couple of exceptions, and that is really smoking status and blood pressure, which just stay the same. So rather than a small improvement, they just stay the same. With smoking status, we have very low number of smokers, and they're followed by our partners in the quit smoking program, which you heard all about earlier this afternoon. Their follow-up is much longer than our program, and so they're really looking at the outcomes there. As for the rest, they all had a modest improvements from baseline to completion. And finally, in terms of outcomes, it's really important that we're always listening to what our patients are saying. And I can just leave this slide up for you to see. But I will note the first comment talks about the parking, definitely a barrier that doesn't exist for the virtual programs. And the rest of the comments really talk about, the comprehensiveness of the program. They were really happy to have someone following them. It allowed them to help make some of those behavior change. And again, it really just brings me back to comment that really the work that you see here and the work that we do in cardiac rehab couldn't be done without our amazing team of healthcare professionals, physiotherapists, nurses, dietitians, psychologists, social work, vocational counselors, and smoking cessation experts. And I really, I hear time and time again comments like the third one, that the clinicians and the team members really care. So again, I can't thank them enough for all the amazing work they've done and having to navigate all the changes in the pandemic. So I did promise resources. I think I know we'll be able to put these in the chat for you, and some of them have already been put there. So we encourage you to access these both for yourselves as well as for your patients. Absolutely, they're there to share with as well. Feel free to reach out anytime to ask any questions of me or anyone else. And with that, I'll open it up to any questions.
Thanks, Jennifer. There is a question from Carolyn. Her question is, post completion of the virtual rehab, how often do you check in with patients to assess maintenance of exercise routines or other outcomes?
Oh, that's a great question. At the moment, we don't have any opportunity to follow up beyond the 3 months, but we always encourage patients to, we leave them with our contact information. And of course, a big part of our end of program process is to really provide them with a lot of resources to help transition them to self-managing in the community. So we're really hoping they're accessing those other great resources in the community to help them continue on. Is there another question?
Questions from the person audience here? Okay. Thank you very much, Jennifer. That was fantastic. Thank you. Okay, so our next presentation will be by Dr. Milnichuk, and she'll be talking about cardiac rehab for patients with heart failure. And just to tell you a little bit of background on Dr. Milnichuk, she's a professor of medicine at the University of Ottawa and the director of the Advanced Heart Diseases program at the Ottawa Heart Institute, as well as vice chair of patient safety and clinical care for the Department of Medicine. She is also cross-appointed to the Department of Cellular and Molecular Medicine. She is a translational scientist and currently holds a University of Ottawa chair in heart function research, has more than 100 peer-reviewed papers, and has built a multidisciplinary right heart failure research program at the University of Ottawa. Provincially and nationally, Dr. Milnichuk is an active leader for the heart failure and pulmonary hypertension community and is vice chair for the Pulmonary Hypertension Association of Canada. Welcome, Dr. Milnichuk.
Thanks so much, and thanks for the invitation to speak here. I think I have about 20 minutes, is that right? To chat with you, and happy to have more discussion. So I'm going to take things a little bit differently today. I'm going to really use this opportunity to talk largely about where we are in 2022 with heart failure management. We'll touch a little bit on sort of the particulars of cardiac rehabilitation. I'm not, you probably in the audience know more about cardiac rehabilitation than I do, but I'm going to really contextualize it as one of multiple facets of optimization of heart failure care. Kind of going just right into it, these numbers are probably familiar to everybody in the audience. We know that heart failure is a highly prevalent disease. We know that epidemiologic estimates suggest that the median survival for this disease is still very suboptimal, and it is a significant burden both to patients as well as to the healthcare society with respect to admissions and costs of care. We also know that the prevalence of heart failure is going to continue to increase, and there's lots of reasons for that. Some of that has to do with the aging population. This is a disease of the elderly in many ways, and also because as we get better and better at surviving from incident myocardial infarctions, we are still left with the burden of scar and what we call stage B heart failure, which is the risk of heart failure without clinical heart failure. And so the numbers are increasing. Globally, there is variability in different regions, but we're really looking at a very high number with overall prevalent estimates anywhere from 1% to 3% of all adults with a diagnosis of heart failure. So a very important disease. We also know that this is a progressive disease. We're going to talk a lot in the next few minutes about all the great medications on the landscape of treatment, but this is a disease that continues to progress. And so when we talk about cardiac rehabilitation, we're really talking about opportunities to intervene for our heart failure patients even before they have heart failure. And that's why this is, I think, such an exciting place to be and to discuss this, because, the team involved in rehab is involved in the prevention of heart failure, right? So you guys are the first line at seeing these folks who have risks for cardiovascular disease and perhaps maybe not even cardiovascular disease. And unfortunately, you also see patients who have cardiovascular disease. They've had an MI, they've had some degree of cardiac procedure, and that puts them at risk of heart failure. And then I live in this world where I look after patients who have worsening heart failure and advanced heart failure. And I can tell you quite confidently that there is a role for cardiac rehabilitation at each one of these stages of disease. Now, the expected benefit you get from cardiac rehab may be different in different stages, but there's very important reasons to think about cardiac rehab at all spectrums of heart failure diagnosis. So when we talk about the core components of cardiac rehabilitation, again, you know this better than I do, we're really talking about a multifaceted way at intervening at our patients to improve their morbidity, their quality of life, and even perhaps their mortality. But one really important aspect of concurrent care is the optimization of medication. And that's perhaps done to a certain degree in the context of the rehab environment, but certainly done to a large degree in the context of our clinic environment. And so that's really what I want to focus on, because really there's so much excitement in heart failure over time. You can see this explosion of heart failure clinical trials in the last 10 years. The way we treat HFrEF or reduced EF heart failure is very different today than it was many years ago. And so you've probably seen, if you're involved in heart failure care, the new guidelines that were put out at the end of this past year that really emphasize for all HFrEF patients, they should be on 4 medications to treat heart failure. And we call those the foundational therapies. And they include an angiotensin receptor neprilysin inhibitor, ARNI, so Entresto, or some RAS inhibitor like an ACE inhibitor or an angiotensin receptor blocker, the ARNI being preferred over the other two, a beta blocker, a mineralocorticoid receptor antagonist like spironolactone or eplerenone, and the fourth new kid on the block is the SGLT2 inhibitor, dapagliflozin or empagliflozin. And all of our HFrEF patients who can be on those drugs should be on those drugs. If you look at the American guidelines, which were actually just published just a few weeks ago, again, they emphasize this 4 foundational therapy for all symptomatic HFrEF patients. And you should titrate and add and modify based on clinical profile. Now, we don't have time in 20 minutes to go over this in great detail, but it is there. And even if you look at the European guidelines for heart failure management, you can see again this idea that all patients should be on these 4 therapies. We should layer in and add in based on the profile after that. And I put this one up specifically because I like the fact that it emphasizes a rehabilitation approach, exercise rehabilitation. And you can see that sort of in the green bubble at the bottom. And unfortunately, our own Canadian guidelines didn't address rehab to the extent that I would have liked to have seen this in the past iteration. So these are the 4 foundations, and there's no debate that they are really the cornerstone in management for our HFrEF patients. And if you want to know numbers, very easily you can see the incremental reduction in mortality risk when you layer on these therapies, going from a 35% chance of death at 2 years down to less than 10%. But there are lots of different ways we can look at this. This was a really nice study that actually compared the 4 foundational therapies to just beta blocker and ACE inhibitor. And depending on your age, your event-free survival increased anywhere from 8 to 14 years. So that's really important information for our patients to help encourage them to be on these treatments. And this was another study that looked at all kinds of different combinations of heart failure medications. Those 4 foundational ones are up there on the top line. And you can see that in terms of mortality reduction, by far and away, it's that 4 therapy combination that is going to give you your biggest bang for your buck in terms of mortality reduction. And so that's really important. However, it's not just about those 4 medications, because as we all know, unfortunately, there's many reasons why our patients are not on goal-directed therapy. And we know from lots of studies that there's something we call clinical inertia, right? We're not very good as we think we are at optimizing therapy. And this was from a large registry called the CHAMP-HF registry that was done a few years ago now, but said that at the end of the observation period, less than 1% of HFrEF patients were on all 4 drugs at all right, or 3 drugs at this time, because this was before SGLT2 inhibitors, at the right doses. And in this other study, this was a clinical trial in the hands of experts in heart failure. Only 15% of the heart failure patients were on optimal medical therapy at 6 months. Not surprising, right? We see this, you see this in your rehab patients. So why is that? Well, in this study, medication intolerance was a big problem for failure to titrate. And this is data from Montreal, from my friend Annick Ducharme, who looked at her own clinic. And she said, absolutely, there's about 20% of our patients in whom we're not doing a good job. They could be on these drugs, but they're not on these drugs. And yet there's another 20% of these patients who actually can't be on the drugs because they have renal failure, they have hypotension, they just don't tolerate them. And so this is really where it starts to get important about what else can we offer them. And I'm here to say I think rehab is part of that. Sometimes you get them on the drug and they actually just stop the drug. This was a beautiful study, a multinational study that showed in new onset HFrEF patients at 1 year, if you can believe it, 40% of people stopped taking spironolactone and about 25% of people stopped taking the beta blocker. So we have challenges, right? We can't get them on the treatment and we can't get them to stay on the treatment. And maybe some of that is provider-based. We're not as good as we think we are or should be. And some of that is patient-based. And in the real world, there's lots of data to suggest that it's hard to get patients on optimal medical therapy because of the things we talked about. I'm going to skip through this just for the event of time. And so one of the things that we do in the clinic encounter, and also you do when you're reconciling medications and in your encounters with the patient, is every time we want to change their treatment, we have to weigh this risk and benefit. And the ideal heart failure patient who's robust and doing well and can tolerate any of those 4 drugs is the best kind of patient to have, but it's also the most infrequent patient that we see. And the reality is the comorbidities, the frailty, the renal dysfunction really affects our ability to do the things we want to do. One of those things, of course, is hyperkalemia. We've all seen this. This is a big limitation to using RAS inhibitor therapy, and it's not uncommon. 15 to 20% of our patients have it. And you know that if you have hyperkalemia, you're not going to do very well. There's this U-shaped mortality. So if your potassium is less than 3.5 or over 5.5, your risks of death are much, much greater. And the drugs we use cause hyperkalemia. So this is a big problem for getting our patients with HFrEF on things like spironolactone, because the drug causes hyperkalemia and is a frequent reason for discontinuation. There's also this problem of low blood pressure, and you see this in rehab and we see it in clinic. And again, like hyperkalemia, we know that the lower your blood pressure is in heart failure, the worse your prognosis is. So it's very different than the patients that we're seeing in rehab that are sort of walking well, stage B patients, where actually higher blood pressure is worse. In our heart failure patients, higher blood pressure is better because it allows us to titrate medications. And we also know from multiple studies, this was a study from using Entresto, that patients were much more likely to stop that medication than compared to an ACE inhibitor because of low blood pressure. And in fact, if you look down here at the bottom, if your blood pressure was less than 110 at baseline, there was a 25 almost % chance that they were going to be stopped their treatment. So again, this is the problem that we have. These drugs are great, but they're only great if we can use them. And one of the things that I think is really important when we talk about patients not being able to tolerate our medications is recognizing that for many of our heart failure patients, the disease is progressive and they may transition to what we call that stage D phenotype of heart failure, the advanced heart failure phenotype. And only a small percentage of those patients will be eligible for advanced therapies like transplant and LVAD. And for many of those patients, it's important to have discussions of goals of care because that's the other option. And so what we emphasize is this idea that recognizing this very critical transition point is important because that's where we have to say, are we going to go left, ramp up our therapies, evaluate them for transplant, or are we going to really focus on things that are going to help them to feel better? And some of this mnemonic, I need help, can guide that, right? And one of the things on that list is an inability to titrate or initiate goal-directed medical therapy. So if you've got a patient like that and you're seeing a patient like that in rehab or in clinic, that's a sick patient. And this is data from transplant. Again, the smallest percentage of the pie of our patients will ever get a transplant, but by far and away, it's the best way to improve outcomes, right? With median survivals well over 10 and 12 years now. Similarly, with LVADs, we have median survivals now that exceed 50% at 6 years. And this is in a patient population that probably has a median survival of 6 months, right? So these are really good therapies, and we don't want to miss opportunities to provide these therapies to eligible patients. However we look at it, though, these therapies are good. They work well when we can use them. But even if we use them, the risk, what we call the residual risk, is still high. This is a number of recent heart failure clinical trials. And in blue, you see people that were on the active therapy. And the risk of 1 year for CV death or hospitalization is still very high. And you can look at it another way. Here's 2 of the most recent SGLT2 inhibitor trials in HFrEF. And even if they got the SGLT2 inhibitor, you can see, their risk of having CV death or hospitalization is not small, 15 to 30% over a couple of years. So the drugs do work, but we need to do more. And each time our patients come back to us and they have clinical worsening and they get into hospital, they are on a completely different morbidity curve. And we know this. And so that hospitalization for heart failure is a really important marker of a patient who's going to do poorly. And the other interesting thing is, and for those that have been on the inpatient wards, you see this, the time frame between one hospitalization and the next gets shorter and shorter every time they come into hospital, right? So it starts at 160 days and then it reduces by about a month every time they go into hospital. So there's a cycle here, right, where these patients are getting sicker and sicker. Worsening heart failure used to be thought of as a patient who's hospitalized for heart failure, but I can tell you that it's much more than that. In fact, worsening heart failure is the patient that you're just increasing the diuretics on, the patient that you're referring to rapid intervention clinic to give IV Lasix. This is a patient who will have a clinical event of significant importance or death in the next 6 months. And we've seen that very well. And I'm just, for the event of time, I'm going to skip over this piece. And I'm going to go back to the guidelines. So as I said, our guidelines didn't address cardiac rehab to the way that I would have liked. However, the foundational therapy is there at the top line. You can see all patients, and then you can see personalization of care, looking for things like defibrillators. Again, we don't have time to go into this, but I bring it up because Where does cardiac rehab fit in this? Well, in my opinion, it fits longitudinally. It's a cross-cutting theme. As I've already said, at all stages in heart failure, from prevention to advanced therapy, there's a role of cardiac rehab. But I also think at all stages in the management of our HFrEF patients, there's a role for cardiac rehab. Now, again, I'm not here to prescribe the type of exercise, but I will say that, and you know this, that our heart failure patients are really complicated. Right? And it's not just their LV function that creates an inability to exercise or to do physical activity. And you also know that the HFrEF patients, the low EF patients, are very different than the patients who have preserved ejection fraction. And then there's this middle cohort of patients with EF of 40 to 50%, and they look different as well. And so when we talk about cardiac rehab for heart failure patients, it really does need to be personalized. Just like we personalize those medical therapies we talked briefly about, we have to personalize the type of rehab that these patients will benefit from. And important contributors to their exercise intolerance are things like pulmonary hypertension, atrial fibrillation, frailty, deconditioning, obesity. All of these things will affect the ability of the patients to have a successful experience in rehab. And just want to bring up two very particularly important phenotypes of heart failure as it relates to rehab and training is the HFpEF patient. And you've seen many of these patients, I'm sure, in your travels. And exercise intolerance for these patients is multifactorial, right? We know that it's not just their heart failure that gives them exercise intolerance. It is their sleep apnea, their atrial fibrillation, their deconditioning, their obesity. And so when we look at the sum total of evidence to support cardiac rehab in HFpEF, you might not be surprised to see that actually the data is fairly mixed. And that's not surprising because this is a very heterogeneous group of patients. But if you ask me what's the benefit in the HFpEF patient, I would say there is absolutely a benefit. And systematic reviews suggest that when done successfully, it does improve the patient's VO2. Now that may be non-cardiac, but that's okay because at the end of the day, we want the patients to feel better, right? And if we can improve some conditioning, then that's a win. There's also evidence to suggest it improves functional capacity and it improves quality of life. What it doesn't do is it doesn't impact survival or heart failure hospitalization or other hospitalizations. And that's okay, again, because the sum total of which suggests that patients want to feel better. And that's a very meaningful endpoint for our patients. The other group of patients that we have to consider are the elderly and frail patients, right? Because these patients are also at great risk. And again, it's the arthritis, the neurologic, the sarcopenia that all influence their ability to exercise and to successfully complete rehab. But again, there is data in elderly, frail heart failure patients that their quality of life is improved, their exercise tolerance is improved with rehab. So these are not contraindications to referral. And then the last group of patients are the ones that I see, the ones with the very low ejection fraction, less than 30%. Is there evidence that they benefit from rehab? Absolutely. They benefit in many ways, but their surrogate endpoints, meaningful endpoints, their quality of life, their improved health status, they feel better. But again, if you look at all of the trials in this patient population, there's not a substantial benefit in mortality, but that shouldn't dissuade us from doing things. And so what do I recommend when we have a patient in front of us and we're thinking about optimization of therapy and cardiac rehab? I think we have to really take a patient-centric approach. We have to look at the patient's goals of care, their hemodynamic profile, and are they at particularly high risk in the fact that they've just been admitted to hospital? Because if that's the case, then we want to be very aggressive, offering them all things that will help them to feel better and live longer. We have to look at their functional capacity, their frailty, their renal function. All of these things will dictate what we decide to do, both in terms of medical therapy and in terms of rehab prescription. And so there's not one way of doing this, and I think that that's important. And so I do layer on the 4 foundational therapies. I then personalize the therapies based on particular attributes, such as atrial fibrillation, clinical worsening. And again, we don't have time to go over that, but there's particular drugs that can be targeted to particular strategies. But I think cardiac rehab is an important cross-cutting theme for all of these patients. And then the other three questions that I encourage all patients or all providers who are involved in heart failure to ask is, one, have we done everything we can do to get them on the right medical therapy? When you see these patients, are their medications missing? And if so, ask ourselves why. Two, are we looking at a patient who has transitioned to end stage or advanced stage D heart failure? And are they a candidate for referral for transplant and VAD? Because that's not a window of opportunity we want to miss. And three, and this can be done all along the spectrum of heart failure, have we sufficiently addressed goals of care and advanced directives? What do the patients want? Asking them is actually probably one of the most important things, because that will dictate what treatment guidelines, options, referrals that we go to next. So in summary, and I'm happy to take questions, absolutely, we've made incredible gain in 10 years. The 4 foundational therapies are here to stay. Every HFrEF patient should be on them. But I've shown you data that suggests that not every HFrEF patient can be on them. And although we can do better in pushing the envelope, there are certain patient characteristics in which suboptimal therapy is unfortunate reality for them. In all heart failure patients, particularly those patients who are most vulnerable because they can't be offered the best goal-directed medical therapy, cardiac rehabilitation is an excellent modality to help our patients feel better and live a better quality of life. And I'll stop there, and thanks so much for your time.
Thanks so much, Dr. Milnichuk. We do have a question from our virtual audience from Julie. This is a question in regards to blood pressure and kind of the monitoring of it for patients in cardiac rehab. So it's a question from Julie. Her question is, what would be an ideal blood pressure for heart failure patients that are attending cardiac rehab? And what would be concerning blood pressure readings?
Yeah, thank you, Sandra, and thank you, Julie, for that's an excellent question. You know, blood pressure recording in and of itself is a tricky thing for our heart failure patients because it doesn't always represent adequacy of perfusion. So I do use blood pressure, but I use it more in the context of how well they're feeling. So if you have a heart failure patient with a blood pressure of 95 systolic and they're not lightheaded or dizzy, I'm not worried. I think that that's a fine blood pressure. And if they want to exercise and they're not symptomatic, I am not worried. Does it affect my ability to titrate medications? It does. But on the other hand, I don't stop therapies for an asymptomatic blood pressure of 95 or even an asymptomatic blood pressure of 90. I encourage those patients to continue to be as active as they're able, and I keep them on the therapy. I may not increase it, but I don't decrease. Now, a patient who is symptomatic is a different story. So a patient who comes and says, you know, I'm trying to do the things you told me to do, but every time I get up, I have to hold on to the wall, or I'm very lightheaded if I turn too quickly and I've fallen, then that is a patient that even if their blood pressure is 110 or 115, we may need to dial back the medications. And so I take it into the context of their symptoms really when I'm providing some advice.
Thank you so much, Dr. Milnichuk. And on that note, Ariane is asking, are there any cases or exceptions in which exercise would be contraindicated in heart failure patients?
Yeah, that's absolutely a very important question, and that needle has shifted a little bit over time. We used to think that class 4 patients, you know, patients with very advanced symptomatic heart failure, symptomatic at rest, shouldn't exercise. We used to think patients with pulmonary hypertension shouldn't exercise, and there was certainly concerns in regards to pulmonary hypertension or advanced heart failure, particularly right heart failure, that if you exercise and you become hypotensive with your exercise, you're at great risk of developing RV ischemia, worsening pulmonary hypertension, and a lot of things. The needle shifted a little bit now. So I do refer functional class 3 patients, functional class 3B patients, patients with moderate pulmonary hypertension for rehabilitation. I'm still very, very cautious though of that class 4 patient. does that mean they can't benefit from rehab? I don't think that's the case, right? Because there's lots of things in cardiac rehabilitation that might actually be of value to them. And I still encourage them to do some level of physical activity, even in fact, if it's just in the bed or in the chair, some simple repetitive movements of their arms and legs to try to, as much as I can, mitigate the risks of frailty and progression of disease. So I almost never say no exercise. It's a question of amount and severity.
Thanks so much, Dr. Milanchuk. That's very helpful. There are no other questions, it looks like, from our virtual audience, so I'll bring it back to Bonnie.
Thanks, and I didn't ask if there was questions from the in-person audience for Dr. Milanchuk before she heads off. No, okay, thank you very much, Dr. Milanchuk. That was amazing as always. Thank you. And so I'm just going to follow up a little bit on what Dr. Milanchuk was talking about in terms of cardiac rehabilitation, and talk about the heart failure program that we've developed here briefly. Try not to repeat a lot of the same information. Dr. Milanchuk was actually the catalyst that got us going on a targeted heart failure program at the Institute. So she's gone, but she deserves a lot of the credit for that. Okay, so the first thing is talking about teamwork, and the heart failure program is unique in that it has healthcare providers from our inpatient program that actually come and work with patients and teach in the heart failure outpatient program. So that's an amazing collaboration. So we have clinical nursing educators, various advanced practice nurses, and they've really been instrumental in developing this amazing program. And I'm all about collaboration and bringing these two groups together as much as we can. It's better outcomes for the patient. So I think Dr. Milanchuk said this very, very nicely in terms of the benefits to the patient in the European Society of Cardiology position paper, again, very, very loudly. So traditional cardiac rehab programs, it's not that heart failure patients weren't benefiting from them. It's just that a lot of the information wasn't specifically targeted enough to meet the needs of heart failure patients. And over the time, heart failure patients did tell us that. They'd say, you know, why are we talking about the cholesterol? Really, I should be talking about, I want to know about my symptom management, what I need to watch for, the nutrition information. It was great, but really I have all these other questions about sodium, fluids, et cetera, et cetera. So it wasn't specific enough, and we knew we had to develop a program that was very specific to these patients. So how is it, what does it look like? So the heart failure cardiac rehab program pathway, patients come in for the same intake assessment that Jennifer spoke about earlier, which includes baseline assessments and relevant referrals to various healthcare providers like psychology, vocational health, social work, etc. Then patients are registered in an 8-week virtual heart failure education series, which I'll talk more about in a minute. In addition to that, they are registered for 5 virtual or 5 on-site exercise classes as well. They have access to a case manager, which is a registered nurse or registered physiotherapist at any time for questions and ongoing support. And then they have an end of program evaluation with that case manager. So the 8 weeks, so there's a different session provided every week to these patients on Epic Zoom. So it's through MyChart, so it's very secure. And then in addition to that, for patients who don't have access to the internet, we also have a teleconference option, which many patients use, and it works very well. So that's the list of series. So we have the basics of what is heart failure. There's a couple of nutrition classes taught by our dietitian, physical activity and energy conservation by our physiotherapist. Managing your medications is by our advanced practice nurse in cardiology. Mind the Heart by our clinical psychologist. Advanced care planning by the advanced supportive care nurse, and transitions by our heart failure advanced care nurse. So just a little bit more detail as to what each session is about briefly. So the early session, this one is actually taught by our clinical nurse educator from CCU. And she talks about how to recognize your symptoms, understanding what is heart failure. A lot of times in the hospital, patients forget all the information that we've taught them for lots of good reasons. Understanding what resources are available and how to look at their symptoms. So most of the time, patients are provided with the heart failure daily weight tracker in hospital. So we get them to get the tracker out and we review it again, answer questions, and make sure that they're really comfortable with using this really important resource. So that's the first session. Kathleen Turner and Joanne McNeil, our two outpatient dietitians, teach the two nutrition classes. They're very popular. So the first session deals more with sodium, fluids, and general heart healthy nutrition. And then the second session is more on meal planning. Really popular one with patients is actually all the recipes. The mind, the heart session that the psychologist teaches helps patients recognize that, emotional up and downs are a normal part of managing heart failure or having cardiac related condition for sure. She reviews the link between stress, anxiety, and depression and heart health. Strategies like the top 10 tips, practicing breathing exercises and things like that the patients can use to help manage their emotional health, to help their heart. She outlines in-house and community resources that patients can also access if they need more support. In terms of physical activity, there's a lot on walking programs. As Dr. Milichuk mentioned, we're looking at a broad spectrum of patients with not the same level of exercise tolerance. So safe exercise, energy conservation, building up a walking program, and really encouraging patients that every little bit counts, which it does. You don't have to join a gym, you don't have to be a marathon runner, and all these things are so important to increasing our patient positive outcomes. Medication management is also very popular with patients. Lots of questions here. And so the advanced practice nurse for cardiology walks the patients through the various heart families, how they work, side effects, extremely popular, and what to do about side effects. When do you call your doctor or your pharmacist? Safe medication practices, renewing your prescriptions, making that link with blood work as well, really important. Advanced care planning, which is, as I mentioned, taught by our APN for supportive and palliative care, who you're going to hear from in just a minute from now. This session, it is one session, and when we were doing focus tests with patient groups, when we put this program together, the patients really wanted this in 2 or 3 sessions. It was like the amount of questions they had and the importance that they placed on this particular subject. Even for me, after nursing here for 35 years plus, it truly surprised me. Patients really need this information, and not just patients, families. And so it's a really valuable part of our heart failure program. So thoughts about goals of care, and even getting down to the difference between a substitute decision maker, power of attorney. Most people don't know that. Many healthcare providers don't either. And talking about the diagnosis of heart failure and the impact on patients' goals of care, etc., etc. Transitions is the last one. And that's the one where basically we try to pull everything together. And so Carolyn Doyle Cox, the APN for heart failure, pulls all the important aspects of all the sessions together in this one. So medication, symptom management, keeping a food diary, knowing when to call your doctor. And then she also gets into symptoms and get, reinforces that really important. That keeps our patients out of hospital. And then community resources as well for when they leave cardiac rehab so that they feel supported as they move along. And then we also have a heart failure support group here as well. So we're really encouraging all patients with heart failure to join. It's a lot of fun. The information is on this slide. So really any patient with heart failure and their spouse and key learner is welcome to attend. So the virtual sessions, that's a picture of one of our amazing physiotherapists who does virtual exercise. So the patients can sign up for 5 weeks of these virtual sessions or come on site. This program has been quite intensively evaluated with a lot of patient feedback. Actually, we have ongoing patient surveys. We track attendance, which is very high. We held focus groups. We look at our pre and post results, which have been equally as good for heart failure patients as it is for our regular population, and with provider feedback as well. So I have a proposal for you. We would like to share this program with you if we can. There's various ways that we can look at that, and that's probably better in sort of a one-to-one discussion. So if you're interested in being part of or having this heart failure program within your center, please let us know. The last slide will have my contact information as well as Jennifer Harris's, the manager of cardiac rehab. So we'd be happy to help you set this up within your institution, share all of our resources and learnings, and support you. So thank you very much. That's our contact information. If anyone has any questions, I'd be happy to answer.
Thanks, Bonnie. There is one question from Maurice. She is asking, can a cardiac rehab patient from another institution like Winchester access these great heart failure education sessions?
Absolutely. We can put the link in the chat, I think, for the classes that we've actually recorded and put on the website, the same as our regular virtual education series. So we'd be happy to do that. And we'd be happy to chat more in person or virtually, however, to make that happen for sure. Okay, thank you very much. So we are running a bit over. So I'm going to introduce now Freya Kelly, who's going to be talking about the cardio-oncology pilot program in cardiac rehab. So alongside Dr. Carolyn McGinty, Freya has developed and is the APN for the Heart Institute Cardiac Supportive and Palliative Care Program, and has recently added the amyloid clinic to her portfolio as well. Having worked in cardio-oncology since 2011, Freya continues to have a strong interest in this field, and being the successful recipient of an RNAO Advanced Clinical Practice Fellowship grant, it has allowed her to continue working in this field with the development and implementation of a pilot project titled Cardiac Rehabilitation for Cardio-Oncology Patients. Welcome, Freya.
Great, thank you so much. So I first wanted to thank Bonnie and the Cardiac Prevention Rehabilitation Division here at the Heart Institute for inviting me today to speak with you about an area of cardiac care that I'm very passionate about and have been for over a decade. So though you'll see my title is APN for Cardiac Supportive and Palliative Care, I have had a substantial interest and background in cardio-oncology, especially as it relates to the research side. So therefore, I'll be speaking with you today about our pilot project for cardio-oncology patients being referred to our Cardiovascular Rehabilitation Program. So my hopes for you today is that you'll leave with a bit of background on cardio-oncology, the pilot population we have decided to target, and our objectives for this project. So as a bit of background, with advances in early detection and treatment, the number of cancer survivors has steadily increased since the 1970s. So survivorship is defined as the phase that follows primary treatment and lasts until cancer recurrence or end of life. So following secondary malignancies, cardiotoxicity is the second leading cause of long-term morbidity and mortality among cancer survivors. Cardiotoxicity is defined as the direct effects of cancer treatment on heart function and structure. Cardiovascular complications of cancer therapy are generally categorized into one of 9 different categories, including myocardial dysfunction and heart failure, coronary artery disease, and arterial hypertension, just to name a few. So although commonly seen as a late effect of cancer therapy, the time point when cardiotoxicity manifests itself can vary substantially. Moreover, with the advance in molecular targeted cancer therapy, there's been an increase in the prevalence of cardiotoxicity among cancer survivors. Cancer survivors who live 5 years past their diagnosis have a 1.3 to 3.6-fold increased risk of cardiovascular specific mortality and a 1.7 to 18.5-fold increased incidence of cardiovascular risk factors such as hypertension, diabetes, and dyslipidemia. So if we compare this to people with diabetes, for example, those with diabetes are only twice as likely to have heart disease, and yet we're fortunate enough here to have a whole program dedicated to diabetes to help avoid further cardiac complications. So moreover, as the Canadian population continues to age, as Dr. Melnichuk alluded to, this adds yet another layer of risk for future cardiovascular disease to this patient population. So what can we do to help those at risk for cardiotoxicity among cancer survivors? One solution that has been proposed in the literature is cardiovascular rehabilitation. So there's been a lot of interest from all involved key stakeholders, and a working group was put together prior to the rollout of our pilot project. It was decided by the physicians at the Ottawa Hospital Cardio-Oncology Clinic and our management team here at the Heart Institute that our pilot project would be aimed at a specific subgroup seen by TOH Cardio-Oncology Clinic, notably breast cancer patients treated with an anthracycline alone, as well as breast cancer patients treated with anthracycline and trastuzumab, who also have a decrease in their left ventricular ejection fraction. This was estimated to be about 40 patients per year that would be referred to our rehab program. So the objectives for this project included identifying and recruiting key stakeholders to support this initiative, setting up a pathway for these patients, developing an auditing tool, holding informal interviews and group sessions with the key stakeholders to examine ongoing barriers and facilitators, developing an education booklet for staff, and developing a brochure or booklet for this patient population. So we were fortunate enough to be the successful recipients of the RNAOA CPF, a fellowship, to help fund this project and provide us with a nurse coordinator to dedicate her time for this project. So I do apologize, the sizing for this is really small, but it's just to show all the short and long-term outcomes that we anticipate this project having for the patients, the staff, and the greater organization. This was put together for the fellowship application, but I think it's a great way to show the benefits of what we're hoping to achieve with this project, both short and long-term. So I'll spend the remainder of our time going over the objectives we laid out and the results of those to date. So our first objective was to identify and recruit key stakeholders, which is something that was instrumental to this project's success. I've highlighted here some of the key players who have helped this pilot project become a reality. Also highlight at the bottom here that Zana Ali was a master's student that we had who laid a lot of the groundwork for us, as well as Laura Duchesne, who is the nurse coordinator, who has been hired through our grant funding to help run the project. But I do really want to highlight the teamwork that made this possible. So the next objective was setting up a pathway for these patients. Here we have the cardio-oncology, cardiovascular rehabilitation process diagram, which was developed in collaboration with Zana and Jennifer, who you met earlier, the manager of the Heart Institute Rehab program. So this was determined following a systematic literature search that was conducted to determine existing clinical guidelines in cardio-oncology rehab for patients undergoing anthracycline and Herceptin therapy. So following the systematic search, guidelines were selected and adapted using the RNAO toolkit for the implementation of best practice guidelines. So this has been instrumental to ensure, firstly, that those who are referred fall within our pre-specified perimeters, as well as to clarify for the rehabilitation staff what is different from their standard of care and what remains the same for the purposes of the pilot project. So the rehab program will include usual care, such as access to smoking cessation, nutrition, mental health services, and exercise programs, tailored as needed to accommodate this patient population. So next we have a sample of the auditing tool that will be completed to review which programs from cardiac rehab the patients are using and whether they are being referred appropriately. So this is again key to evaluate the feasibility project and again include components such as referrals to allied healthcare providers, number of patient contacts, and program completion. So I recently heard what gets measured gets done, and I think this speaks directly to that quote. So during one of our key stakeholder meetings, a barrier regarding referral process itself was brought up by the staff at the cardio-oncology clinic. So to overcome this particular barrier, the lead physiotherapist from Rehab developed the step-by-step referral slide deck to ensure referrals are standardized from the cardio-oncology clinic. So the lead of the cardio-oncology clinic also put together an epic list for us to review for potential referrals from their clinic. Moreover, we have ongoing meetings with the previously identified stakeholders, as well as an open line of communication expectation to ensure that any barriers to referral are addressed immediately. So to meet the objective regarding staff education, a lunch and learn and staff booklet were developed for the staff at the Heart Institute Cardiac Rehabilitation, with the information in the booklet coming from the literature and subsequent questions from the lunch and learn. To meet the objective regarding education for the patients, the rehab staff are currently offering this infographic. It's available in French and English online for the Canadian Women's Heart Health Centre. It, alongside other standard of care patient education materials, such as nutrition and exercise booklets, will be provided to the patient population. So lastly, to ensure our project is being developed alongside our patient partners, we modified the satisfaction survey currently provided to patients at the end of their cardiac rehabilitation programming to review any further modifications that should be reviewed. So that's just sort of a brief overview and concludes my presentation for today. Again, I do want to thank Bonnie and her team for inviting me today. As I said at the beginning, this is an area of healthcare that I am very passionate about, and I'm so excited that others at the Ottawa Hospital and the Heart Institute share my enthusiasm with this project. If you want to learn more about cardio-oncology, I cannot highlight enough the Global Cardio-Oncology Summit that's held yearly, just to further showcase Ottawa and the work that we have done here for those with cardiotoxicity. The current president of ICOS is Dr. Susan Dent, who actually started the cardio-oncology clinic here in 2008 and clearly continues to do amazing things. Thank you.
Thank you so much, Leah, for that great presentation. I do have a question for you. This question is, how are you capturing patient feedback in this pilot?
So I'll just go back to this slide that at the end of every patient who goes through cardiac rehab, they submit these satisfaction questionnaires. And so I don't know exactly who did it, but someone modified the questionnaire specifically for this pilot population. Sorry. And focus groups.
That's great. Thanks, Freya.
Thank you.
Okay, Sandra, we're going to play spin the wheel.
We will, yeah. Just before we do conclude our session, we're going to draw some prizes for our attendees and those who completed our survey. So just bear with me for 2 seconds.
While Sandra's getting that sorted, I just wanted to thank everyone so much for attending this session today. I hope you found it to be very informative and very applicable to your clinical practice. The recorded sessions will be available in the link in the chat as well.
Great, thank you, Bonnie. We're going to draw some names of those who did our survey here. Right, so our first name here is Gabrielle C. So we're going to connect with you for our prizes. Okay. We're going to do one more.
Congratulations, Gabrielle. Awesome.
We have Madison M as well. Okay.
Awesome. Congratulations, Madison.
And then two more. And Maurice is our third winner.
Marizo, congratulations.
And the last one. We have Ariane. Congratulations to all our winners.
That's great. Thank you very much, Sandra. And also just to mention as well, another plug for the Women's Heart Health Education Day coming October 13th. So we'll be sending out information on what's going to be the content of that day and how to register. Sandra, do you have anything else you'd like to add?
No, thank you so much, everyone, for just joining our session today. It was such a great day with excellent presentations and such great participation from everyone. So we're very pleased. And yeah, we hope to host future events that involve you guys, include you guys. Yeah, if you have questions or comments, myself and Bonnie are happy to take them. But yeah, we're just so thankful that you've joined today.
Thanks, Sandra. Thanks, everybody. Have a great rest of your day.